Everyone have joined. So I'm going to start today's webinar. Good morning, everyone. Thank you for joining us for today's webinar. My name is Sanjana and I'm the coordinator for this oral session. It's given me a great pleasure to extend to you a very warm welcome on the behalf of AIMS Rishikesh, who has clubbed all of us for the National Conference of Epidemiological Foundation of India, Eficon 2020. You can't enjoy well if you are not good in health. So, with an object of non-communicable disease, I feel proud to host the oral presentation session. I feel extremely glad to welcome our chairperson. Dr. Sridhar Radana ma'am is Associate Professor in the Department of Community Medicine, Sri Guru Ramdas Institute of Medical Sciences. She is heading National and International Collaboration. I feel extremely glad to welcome our chairpersons. Our first chairperson is Dr. Harivansh Chopra. He is Professor of Community Medicine in LLRM Medical College, Meerut. He has teaching training, treating and preventive experience of more than 36 years. He has established Urban Health Training Center at Suraj Kund, Meerut. He is the only teacher from the Uttar Pradesh to have recorded 31 lectures in the first virtual medical university in India. He has been the recipient of Visionary Leadership Award at South Asia eHealth Summit in 2015, Best Paper Award at Faculty in IAPSM Con UP UK chapters. He has published more than 90 papers in various national and international journals and has written a book on doses of common drugs in pediatrics. Our next chairperson is Dr. Arvind Kushwaha. He is additional professor in AIMS Nagpur. He has served in AIMS Armed Forces Medical Service since 28 years. Since August 2018 at AIMS Nagpur. His field of interest is outbreak response and epidemic preparedness and mental health. He is member of IPHA, IAPSM, ISM OCD, RSPH, RFHA, ISID, ISTM, and he is member Central Team for Maharashtra for Pandemic Response, and he is designated Public Health Specialist for Maharashtra for COVID-19. Our next chairperson is Dr. Sneha Kumari. She is Assistant Professor in Department of Community Medicine, ESIC, Medical College and Hospital, Faridabad, Haryana. Ma'am presently working as Assistant Professor in Department of Community Medicine of ESIC, Medical College and Hospital, Faridabad, Haryana. Ma'am is member of following professional bodies like IAPSM, IPHA, IAYAHFEFI. Ma'am has more than 40 publications in peer-reviewed index, national and international journals. Ma'am is assistant editor and reviewer of many index journals. Ma'am have written various chapters in community medicine book and assistant editor of National Health Program by Jugal Kishore. Ma'am have already presented more than 30 research papers and posters in several national and international conferences. And ma'am has written one unit of IGNU for MSc students. I'm the coordinator of this session. My name is Sanjana Dharra, and I'm currently pursuing my master degree in psychiatric nursing specialty from AIMS Rishikesh. And I have pursued my BSc nursing degree from AIMS Rishikesh. And I had worked as a nursing officer in Department of Anesthesia OT at AIMS Rishikesh, and I'm a member of Student Nurses Association. And I'm and I had worked as a nursing officer in Department of Anesthesia OT at AIMS Rishikesh, and I'm a member of Student Nurses Association. Now move forward. Our first speaker is Dr. Mayank Raj. His title is A Study on NCD Screening Among Postgraduate Students in a Teaching Hospital of Ranchi, Jharkhand. Sir, please. Over to you, sir. Dr. Mayank Raj.
Yeah, good morning.
I work as a nursing officer in Department of Anesthesia OT at AIMS Rishikesh, and I'm a member of Student Nurses. So you can share your screen.
Yeah, I'm just trying to share my screen.
Now move forward. Our first speaker is Dr. Mayank Raj. His title is A Study on NCD Screening Among Postgraduate Students in a Teaching Hospital of Ranchi, Jharkhand. Sir, please. Over to you, sir. Dr.
Yeah, just trying to share my screen. Just 1 minute.
So you can share your screen.
Yeah, I'm just trying to share my screen.
Now move forward. Our first speaker is Dr. Mayank Raj. His title is A Study on
is my slide visible? Is my slide visible?
Over to you, sir.
Yeah, Dr. Mayank, your slides are visible. All the other participants are requested to mute themselves. Except for the chairperson, all are requested to mute themselves. Sir, can we start, sir? Chopra, sir?
Yeah, absolutely.
Yes.
Okay. So a very warm good morning to all my respected teachers. I'm Dr. Mayank, and the title of my study is Study on NCD Screening Among Postgraduate Students in a Teaching Hospital of Ranchi, Jharkhand. So coming to the aims and objectives of my study, it is to find out the prevalence of NCDs among postgraduate students of AIMS Ranchi.
Except for the chairperson, all are requested to mute themselves. Sir, can we start, sir? Chopra,
Yeah, definitely. Sure, absolutely.
Okay. So a very warm good morning to all my respected teachers. I'm Dr. Mayank, and the title of my study is Study on NCD Screening Among Postgraduate Students in a Teaching Hospital of Ranchi, Jharkhand. So coming to the aims and objectives of my study, it is to find out the prevalence of NCDs among postgraduate students of AIMS Ranchi.
Except for the chairperson, all are requested to mute themselves. Sir, can we start, sir?
Yeah. Definitely. Sure. He has already started.
So coming to aims and objectives, it is to find out the prevalence of NCDs among postgraduate students of AIMS Ranchi and to identify the major risk factors associated with development of NCDs among postgraduates. Coming to the methodology, it was a hospital-based cross-section study which was conducted for a duration of 3 months in RIMS Ranchi. The study population was the postgraduates of RIMS. Consecutive sampling technique was adopted, and final sample size achieved was 117. So a pre-tested semi-structured questionnaire was used to interview the participants, and a template was generated in MS Excel, and data analysis was done in PSC software version 20. and to identify the major risk factors associated with development of NCDs among postgraduates. Coming to the methodology, it was a hospital-based. So coming to the result section, for a duration of 3 months in RIMS Ranchi, the study population was the postgraduates of RIMS. Consecutive sampling technique was adopted, and final sample size achieved was 117. So a pre-tested semi-structured questionnaire were used to interview the participants, and a template was generated in MS Excel, and data analysis was done. PSC software was done 20. And to identify the major risk factors. Coming to result section. So out of total 117 participants, NCD was found to be present in 13 males and 4 females. So 17 out of 117 students were having any NCD. So prevalence, as we can see, was found out to be 14.5%. Now, coming to this is a graph showing gender distribution of NCDs. So among those in whom NCD was present, so we found that 13 males were having any NCD, while 4 females were having any NCD. This is the graph showing the age distribution of NCD. So 8 people were having an NCD who belong to 20 to 30 years of age group, while 8 people having an NCD were belonging to 30 to 40 years of age group, and 1 person was found to be on the 40 or more than 40 years of age group. So this is a pie chart showing NCD relation with the drinking habits. Now, among those in whom NCD was present, 17.6%. So among those in whom NCD was present, 17.6% were alcoholics, while 82.35% were non-alcoholics. Among those in whom NCD was absent, 30% were alcoholics, while 70% were non-alcoholics. This is a pie chart showing NCD relation with smoking habits. So among those in whom NCD was present, 29.4% were smokers, while 70.5% were non-smokers. And among those in whom NCD was absent, 10% were smokers and 90% were non-smokers. So this is the NCD relation with physical activity. So among those in whom NCD was present, 11.76% did not exercise, while 82.2% exercise. And among those in whom NCD was absent, 25% did any form of exercise, while 35% did not exercise. So coming to the discussion part, the prevalence of NCD among postgraduates was found to be 14.5%. Out of total 117 participants, 17.5% were males and 9.3% were females. 14% students in the age group of 20 to 30 years, 14.2% in the age group of 30 to 40 years, and 25% students who were 40 and above suffered from any NCD. Among those who consumed alcohol, 17.6% had any NCD. 29.41% of the smokers were suffering from any NCD. 11.76% who did not exercise were suffering from any NCD. So coming to recommendations, regular screening of the postgraduate should be done so that there can be an early diagnosis and proper treatment of the condition. Students should abstain from unhealthy habits like smoking, drinking, binge eating to combat stress. Students should indulge in more physical activities, and the students should avoid eating junk food on a regular basis. Thank you, sir.
Thank you, Dr. Mayank.
Yes, sir.
Could you please tell us how could you reach to this figure of 117?
Sir, actually, I tried to interview as many participants as possible.
No, my question
among
is
postgraduates.
How do you calculate your sample size?
Sir, by adopting consecutive sampling, sir.
No, that is the sampling method. I'm asking
Yes,
you,
sir.
how did you calculate your sample size?
So I tried to interview as many participants as possible. So 117 participants actually gave me answer to all my questions.
Dr. Mayank?
Yes, ma'am.
In methodology part, you took consent of participants?
Yes, ma'am. I took prior consent and then I did the interview. Yes,
it was not written in your methodology part. And what about ethical consideration? It should be written in your methodological part because it is one of the important component of methodology.
Yes, ma'am. Sure, ma'am.
Okay.
Thank
and
you,
next question is, which type of NCD you are talking about? NCD is a spectrum of many diseases. Which
Yes, ma'am.
type of diseases you took into your study?
Ma'am, mainly 3 diseases, ma'am. Diabetes, obesity, and hypertension, ma'am.
So you have to write down these 3 diseases only you took under NCD, because NCD is a spectrum of diseases.
True, ma'am.
Okay, and also you have to write in your methodology portion that how you have calculated or identified these diseases in your study. Okay.
Ma'am. Okay, ma'am. Thank you, ma'am.
Any other question from the speaker by any other co-chair?
Thank you so much, Dr. Mayank Raj. It was a wonderful presentation. So our next speaker is Dr. Lima Lamla Jamir. Her title is Diabetes Literacy at a Nascent Medical Institute in Andhra Pradesh, Rapid Survey and Factor Analysis. Over to you, ma'am. Please share your screen.
Good morning. Is my screen visible?
Yes, ma'am. Yes, ma'am. It is visible.
Good morning, respected chairpersons and all present at this session. I am Dr. Lima and I will be presenting our study on diabetes literacy at the newly established Medical Institute in Andhra Pradesh, a rapid survey and factor analysis. India has an estimated 77 million people with diabetes and is the second most affected country in the world next to China. The ubiquitous affliction of diabetes necessitates that every citizen is diabetes literate. Strengthening the integrated diabetes services initiated at the newly established Medical Institute in Andhra Pradesh requires the patients and family members to be current in terms of established medical facts. Therefore, the study was conducted with the aim to strengthen the integrated diabetes services initiated at the newly established Medical Institute in Andhra Pradesh, that is the All India Institute of Medical Sciences at Mangalgiri, which started functioning from 2018 and started the OPD services in March 2019. The study objective was therefore to assess the general comprehension of diabetes mellitus across staff and patients at the newly established Medical Institute in order to capture the prevailing perceptions and knowledge about diabetes. So this was a cross-sectional study conducted at AIIMS Mangalgiri, Guntur, Andhra Pradesh, which is centrally located in this right in the middle of the state of Andhra Pradesh. The study population were ancillary staff such as housekeeping, data entry operators, OPD orderlies, technicians, OPD patients and their attendants, and the study was conducted in November 13 and 14 as part of the World Diabetes Day celebrations and activities conducted by the Institute. A sample size of 200 was calculated, and this was validated by the Holter and statistic, which was shown to be adequate for our study. Study tool. A pre-tested self-administered questionnaire was used in English and in Telugu with 20 statements on diabetes, which were true statements as well as false statements, and the participants had to tick whether they agreed, disagreed, or did not know about the statements. So data analysis was done in SPSS and a confirmatory factor analysis was done to assess the right model. Study was reviewed and cleared by the Institutional Ethics Committee. Coming to the results, these were the 20 statements on diabetes, starting from etiology, diagnosis, treatment, complications, and what they felt about common food facts. So coming to the true statements, most of the participants responded that they agreed to statements such as pre-diabetes can be handled by diet restrictions and physical activity. as well as when we used a different type of question, which was similar to the previous one, such as diet and physical activity help in reducing blood sugar, and also on hypoglycemia, such as low blood sugar can manifest as sweating, dizziness, and shaking. So this is more than 70 to 80%. Coming to the false statements of diabetes. Yes. So coming to the false statements on diabetes in red, we can see that there were some misconceptions, such as diet restriction in diabetes does not include honey or jaggery. Also, diabetes can take jaggery or honey instead of sugar, which was both these false statements were agreed upon by more than 50% of the participants. And coming to a question which participants did not know, 25% of the participants did not know whether a diabetes patient has a fasting blood sugar of 126 milligram per deciliter and above. So these were the areas that we found were significant and required to be addressed in our awareness activities. So this was the final factor analysis model, and considering the relative chi-square value that we used to see the goodness of fit, which was between 2 to 5, our model was 2.059, so it fitted the model. So coming to the final factors that we found, we had found 6 major factors. On coming to risk factors, hypoglycemia, diagnosis, medications, food fats, complications. What we found was, if we have to ask the layperson his or her perception about diabetes and risk factors, this question, high BP and cholesterol are risk factors, was a very good indicator and a very good factor that can be used to assess their knowledge. Coming to hypoglycemia, we found that this question, hypoglycemia manifests as sweating, dizziness, shaking, had the best and the highest critical ratio, and it was highly significant. And it can be used to capture knowledge about a lay person's knowledge about hypoglycemia. Coming to diagnosis, this question, diabetics have FBS 126 milligram per deciliter and above, had the highest critical ratio, and it was highly significant. Coming to medications, whether a diabetic person should stop medications if blood sugar is under control. So this statement can be used to assess a layperson's knowledge about diabetes medications. Coming to food fats, honey, jaggery or honey are sugar alternates. So this was found to be a very good statement or a question that can be put forward in our community to capture their knowledge about food fats. Coming to complications, slow or non-healing infections in feet is the complication of diabetes. So this statement was found to have the highest critical ratio and was found to be highly significant for capturing the common man's perception and knowledge about complications of diabetes. So 6 themes emerged with key questions from the factor analysis. 4 factors were conducive to diabetes control with the most unique item in each factor, which I had just displayed. So coming to risk factors, this risk factor, high BP and cholesterol are risk factors, was the one that was the most unique. For hypoglycemia manifesting as sweating, dizziness, or shaking was the most unique fact item. Diagnosis and for complications also, we found that these statements can most accurately capture a layperson's or a common man's knowledge about diabetes. The other 2 factors showed as to why the above knowledge is not working optimally in community control of diabetes. So people think that a diabetic person can stop medications if blood sugar is under control, and that honey or jaggery are sugar alternatives. So we found that these beliefs also influence diabetes control in the
Sorry to
community.
interrupt you, ma'am, but you are overshooting the time, ma'am. Please be
Just
attentive.
wait, this is my last slide. So limitation, demographic variables were not collected, but our aim was to maintain anonymity of the participants without identifying their designation, especially because it also included staff. So our recommendation is address misconceptions on priority and have periodic reinforcement through awareness activities. Thank you very much.
I request our chairpersons if they have any query or questions, they can share.
Yeah. Lima,
Good morning, sir.
you studied 200 subjects. Were all these subjects were diabetic?
Yes, sir.
Yes or no?
Yes, I could not hear the question, sir.
You did not. You studied 200 subjects. You studied 200 subjects.
Yes, sir. It was a rapid survey, sir, among all the staff and all the patients and their attendants.
So were all these people were diabetic or non-diabetic?
So it was a mix. It was a mix, sir. Some patients were diabetic, some patients were not diabetic, and also we included all our staff.
So don't you think the level of knowledge will be different among the heterogeneous population?
Yes, sir. Yes, sir.
How can you draw the conclusion then? If your sampling universe is heterogeneous,
Yes,
then
sir.
how can you draw the conclusions?
So we just needed a generic baseline idea.
No,
So this is a limitation.
this is a limitation. Okay, I hand over to my co-chairpersons. Anyone else?
Lima.
Yeah.
Morning, ma'am.
Yeah, morning. How did you pre-tested your questionnaire as you have written in your methodology?
Yes, ma'am. Ma'am, so we pre-tested this questionnaire among nursing staff and patients who were attending our OPD 1 week before, because we wanted to capture the perceptions of our patients. So 1 week before we had prepared and we pre-tested among our people who attended 1 week before, ma'am.
But same patient can come after 1 week also for follow-up?
Ma'am, we just ensured that repeats were not there. Like we ensured, like through our data collectors, that there should not be anyone who has been involved in the pre-testing, and do not interview them.
Okay, but sir has pointed very valid point that because knowledge level of all the study population were not the same. Okay, okay. Otherwise, nice presentation.
So can we go to the next speaker now?
Yes, sir. So our next speaker is Dr. Ravi Prasad Verma, and his title is Depression Screening Among Caregivers of Palliative Care Program Beneficiaries in Kerala. Over to you, sir. Sir, please share your screen.
Is my screen visible?
Yes, sir, your screen is visible. Sir, it's just a little reminder, sir. Please, sir, 5 minutes time is given to each and every speaker.
Fine. My title has already been read out by Sanjana, so I'll proceed. The study is based on the palliative care program in Kerala. Palliative care, as we all know, is care of patients with life-limiting illness, as well as their families. It's total care that tries to address physical, psychological, social, and spiritual aspects of suffering. The WHO website at present gives palliative care as a crucial part of integrated, people-centered health services. The Kerala palliative care policy was launched in 2008. There was a legacy of palliative care provisioning by NGOs. One of the founding persons is Dr. M.R. Rajagopal. He received a Padma Shri just a couple of years back. So it was an NGO-driven program initially taken up by the local self-government institution with the then NRHM, National Rural Health Mission, which is NHM now, providing the training. So there is a palliative care nurse in all local self-government institutions, and usually the ASHA worker. Kerala has very good RCH indicators. So the role of the ASHA worker is more towards NCD and palliative care. As you can see, they make home visits and provide care to homebound and bedridden patients. Now, this was actually a study which was trying to develop and validate a tool for measuring caregiver burden in Kollam district in Kerala. You can see Kollam district in the map there. This analysis is based on data. This tool has been developed and it's currently under publication, forthcoming in the Journal of Palliative Medicine. So we are analyzing the data for other outcomes. We screened these caregivers for depression using the primary care screening questionnaire for depression. A little bit about the methodology. Sorry. Yeah, participants were caregivers of palliative care patients in the registers in 5 PHCs. We started off with 7, but because of the COVID conditions, we had to stop with 5. We could eventually get 221 caregivers, of whom 200 were women. So we are restricting this analysis to the 200 women. We had a structured questionnaire in Malayalam with these details, and we had asked for the personality using the Big 5, 10 inventory, quality of life using the Eurocall, and the primary care screening questionnaires for depression. Based on the advice of the Institutional Ethics Committee of the SCTI MST, we had to make our questionnaire very short. So we went for the shortest available tools for these variables. Most of the women were middle-aged with 36% above the age of 55. Most were married. The self-reported monthly income above 1,500 was 44%. A third had stopped working or quit their usual vocation like agriculture because of the caregiving responsibilities. The caregivers themselves, almost half had some medical condition, and only about 10% were actually giving care to a cancer patient. Mostly were for other conditions like dementia, stroke, heart failure, etc. The primary, this PSQ4D is a 4-item tool developed and validated in Kerala, mainly intended for use by the multi-purpose workers and field workers. And this was applied and the screen positive was 20%. I do not call them as depression positive because I'm not treating this diagnostic, but more like a screening tool. Looking at the factors that were associated with depression, we did a bivariate analysis, and those that were significant in bivariate were through a sequential regression model using binary logistic regression. We developed this one finally. Those who had to give up their job because of caregiving were at high risk of being screened positive for depression. Even if only 10% of the caregivers were providing care for a cancer patient, that seemed to be main cause for depression, although we had dementia, Parkinson's, heart failure, stroke, very sick patients, but somehow the cancer stigma may be contributing here. Caregivers reporting pain, again, this could be because of somatization or physical complaints precipitating depression. We don't know the temporality. A self-reported health score of less than 70 in the EQ5D visual analog scale again was a predictor of screening positive for depression. And as far as the personality traits were considered, we expected neuroticism to be associated with depression, but we got agreeableness, and that remained significant. And data, I mean, the findings on agreeableness and depression is conflicting. Some studies show that there is a relation, others don't. So caregivers registered for the state palliative care program may have depression levels that's comparable to other women in rural Kerala. A study in 2017 reported 26% in middle-aged women. So we found actually a bit less. The PSQ4D screen positive persons had patterns of physical, psychological, and social problems consistent with those expected in depression. So we feel that this tool can be used by the palliative care nurses and ASHA workers to screen for depression, and those who are screen positive could be referred to the PHC for further evaluation. So that is our conclusion. Thank you for the opportunity.
Thank you, Dr. Ravi Prasad Verma. It was a nice presentation. Now I would request our chairpersons if they have any query and questions.
Yeah. Thank you, Dr. Ravi, for a nice presentation. I just wanted to ask, you said the objective was to validate the tool.
Yes, sir.
And then you said that you were screening for the presence of depression.
Yes,
And you looked into the modality of the workers who were providing care to people suffering from terminal illnesses. Is that correct?
yes, sir.
But there could be other factors which could be associated. It's not only because ASHA worker is a worker which works on an honorary basis, maybe 4 hours or 6 hours. There could be number of other reasons which could lead to conclude this.
Sir, it's not. I mean, my participants were family caregivers of bedridden and homebound patients.
Okay.
Yeah. So we were seeing whether the ASHA worker could assess caregiver burden.
Okay. Okay.
Whether this tool could be used by ASHA workers to screen caregivers for depression.
Yeah.
If they are depressed, the Kerala government has a program called Ashwas implemented through PHCs for depression. So the ASHA workers could refer them to the PHC on the Ashwas clinic day for the MO to assess and medicate if needed.
Okay. Okay. Thank you. But again, one question which I'm asking from everybody: you studied only 200 subjects. How could you reach to this magic figure of 200? How do you estimate the sample size?
The primary objective was to develop a tool for caregiver burden assessment based on the criteria suggested.
My question is simple. Don't deviate from the question. I'm asking a simple question. How could you reach to this 200 magic figure? All the three speakers, they have reached to a figure. You are not clear what you are doing, basically. If your sample size is not adequate, how can you generalize the findings?
I disagree, sir. I was referring to the paper which recommends 1:5 for 5. Like if there are 25 items in your scale, then the recommended sample size minimum is 1:5. We went for a sample size of 1:10, but fell short because of the COVID restrictions. So we stopped at 1:8. So with 25 items in the questionnaire, 1:8, 200.
You did not mention that in your paper.
I did not.
So I am not a antaryami. I don't know how
I'm
you are.
sorry, sir. I fully agree.
That is the limitation of your presentation. Thank you. Over to the chair, to other co-chair.
What was the prevalence of depression in the population that is screened?
In the population that we screened, we got 20%.
So it's much lesser than what is reported otherwise in general population in Kerala.
Yes, sir.
Especially among the middle-aged women.
Yes, it is 26.
So
looking into
how do you justify this lesser prevalence, and especially in caregivers which are supposed to be more depressed compared to the people who are not caregivers? How to justify that?
We are looking into the sensitivity and specificity of the tool that we used, and we think the paper that validated reported 96% sensitivity, but I am having my doubts whether it's that sensitive.
Or okay. And what was the mean duration of caregiving that these subjects did? Was there any?
There was a relationship between the duration of care. The median duration was 1 year. We categorized as caregiving duration less than up to 1 year and above 1 year. This was significant in bivariate analysis, but not in multivariate.
So you included all the people who were caregiving even for 1 month and onwards, or was there any cutoff which you used? Okay, only after 6 months do we screen for depression?
3 months. Because of the restrictions in the slide, I did not elaborate the methodology. We had a cutoff of having been a caregiver of at least 3 months or more.
Okay. And how this cutoff was arrived at was from some other studies prescribed that minimum duration is for developing maybe after effects of caregiving is around 3 months, or is it or your own criteria?
The first phase of the study, we had consulted 10 palliative care experts, 8 doctors and 7 doctors, 2 nurses and 1 palliative care volunteer with over 10 years experience. we had a face validity of the questionnaire. At that time, we had also asked for other recommendations. So this was a consensus that they suggested that we used.
Okay, but generally what we feel is possibly in developing a depression, even in a caregiver, it would take some time, you know, it may be the 3 months, maybe a little shorter duration. I think maybe 6 months or maybe 1 year would be by the time the fatigue sets in and then the helplessness sets in. Probably, I don't know, really, I've not really read much into it.
No, so it's very right. The induction time is something which
That may be one reason that you have got a lesser prevalence. Maybe if you had studied people beyond 6 months or 1 year, you would have arrived at a different figure altogether.
yes, sir. The induction time required for caregiving to cause depression, we have not considered adequately. That is a limitation.
Thank you.
Dr. Ravi, how you have selected 5 PHCs during your study?
Kollam district has 32 PHCs. We randomly selected 7 from the list of 32 PHCs. And in that, we could complete 5.
Okay, so in this has to be written in your methodology because it's 5 PHCs. And after you screen positive your patients, what you have done with those patients?
Yeah, as I was saying, Kerala about 3 years back has started a program called Ashwas, which is a day for depression. There's a depression clinic in every PHC in one afternoon, usually Fridays or sometimes Tuesdays. So those who were screened positive were referred to that or a doctor of their choice. There was a medical college in the district. So one doctor had given consent for sharing his number. So we gave that number as well as said you could go to the PHC Ashwas clinic or any provider of your choice. We feel that it would be good if you go.
Yeah, okay, okay, thank you.
So can we move to the next speaker?
Thank you all.
Yes, sir. Thank you so much, Dr. Ravi Prasad Verma. Our next speaker is Dr. Ankit Gupta, and his title is Prevalence of Chronic Kidney Disease and its Association with Risk Factor in Eastern Uttar Pradesh.
Hello, everyone.
Can you go to the slide share?
Yes. Are you able to
We are
see
able
the
to
slide?
go to the slideshow. Go to the
Yeah.
slideshow.
Okay. Yes. Hello, everyone. Today's my topic is prevalence of chronic kidney disease and its association with risk factors in Eastern Uttar Pradesh. I am an assistant professor in Department of Biochemistry in All India Institute of Medical Sciences, Raebareli. So first of all, I would like to introduce you with the chronic kidney diseases. Chronic kidney diseases is being diagnosed in the patients having a GFR less than 60 ml per minute per 1.73 meters square for more than 3 months or equal to 3 months with and without structural kidney damage. And it is being manifested by either pathological abnormalities or markers of kidney damage, such as blood or the urine. So in the urine, we diagnose for ACR, which is albumin creatinine ratio. On the basis of the GFR, I would like to introduce that CKD diseases are being categorized in 5 stages. So in these CKD 5 stages, and these are the descriptions which have been associated with the following stages of the chronic kidney diseases. The CKD stage 5, which have a GFR rate less than 15, is known as a end-stage kidney failure or ESRD, which is been cured only by the highly costly methods such as the RRT, renal replacement therapy, or the dialysis. So that's why the patients mostly belong to the rural areas, and those are below poverty line. Those doesn't meet with the medications which are being required at this stage of CKD 5, and that's why the death rate is high. we have just done a simple retrospective observational study in an area adjacent to Raebareli, and we have did the study on around 1,800 individuals or the patients over the period of 1 year. Those admitted, those appeared in the OPD, and we collected their samples in the laboratory, AIMS laboratory, based on the recommendations of the clinicians. And we found that on the total 1,800 people, we found that the people of around 4% individuals were prone to chronic kidney diseases. And based on the GFR rate, we have categorized those patients. Those were diagnosed with the CKD into the 5 stages. And we found that majority of the patients fall in CKD stage 3 and stage 4. And these are the various locations where the prevalence has been reported. So then we looked for the various parameters. Those are being in the kidney. Those are included in the kidney function panel, such as serum creatinine, which is the most important parameter to determine the kidney functionality. So we found that that serum creatinine were significantly elevated in the CKD patients as compared to the normal control subjects. And similarly, the blood urea nitrogen and uric acid were also found to be significantly elevated in the case of the CKD patients. Based on the various urine dipisticases and the albumin creatinine ratio, we also found that these CKD patients, out of these CKD patients, 86.7% patients have a microalbuminuria, means they have a albumin level between 330 to 300 around, and some people have more than that. And we also, and on the basis of this, we found that urine albumin levels were also significantly elevated in the CKD patients as compared to the normal patients. Then after, we looked for the hematological indices to determine their hemoglobin levels, and the patients, the male patients having hemoglobin level less than 13 gram per dl, and female patients having hemoglobin less than 12, they are being diagnosed as with an anemia. And along with the hematological indices, we also did a microscopic study to differentiate between the various anemia such as normocytic, macrocytic, and microcytic. And we found that majority of the CKD patients were prone to normocytic hypochromic anemia, means they have a less hemoglobin as well as their RBC size were normal based on the MCV values, because MCV for the normocytic MCV values are between 80 to 100 FL, and for macrocytic it is for more than 100 FL, whereas for microcytic it is below 80 FL. So we have categorized based on the MCV values as well as the microscopic examinations. And we found that majority of the normocytic hypochromic anemia was prevalent in the CKD stage 3 and 4. So basically, then we looked for the diabetes in the CKD patients, and we found 82% of the CKD patients were suspected or were prone to the diabetes. And the diabetes was estimated based on the blood glucose level and the HbA1c levels. And basically, these diabetic CKD patients were more, means basically they were in the CKD 4 stage. So basically, the diabetic patients, those have a CKD, were in the CKD 4 stage. Okay. But we
sir, I'm extremely sorry for interrupting you, but you are overshooting the time, sir. Please
okay,
time.
just a last slide. And then we looked for the risk factor, and we found that the fluoride, we measured the fluoride levels in the water in the areas where the patients appeared, and we found that the Dalmau and Amawa blocks have a higher fluoride levels, more than 1.5 ppms, and we found that those in these areas, the people were more diabetic as compared to the southern area, which have a less fluoride within the permissible limit of the fluoride concentration in the water. But there was no changes in the urine albumin. However, the diabetic nephropathy were more prevalent in the patients belong to the Dalmau and Amawa block. Those were endemic to fluoride in their water. So basically, this is the schematic that shown that the people that were from the fluoride endemic areas were highly diabetic, and due to the diabetes, they are prone to the chronic kidney diseases, and due to the kidney damage, there was reduced production of the erythropoietin that leads to the anemia. So this is the conclusion. Fluoride appeared as a major environmental factor that seems to be contributed in the prevalence of CKD in eastern Uttar Pradesh, particularly in the Raebareli district. Yes, thank you. Yes.
Thank you so much, Dr. Ankit Gupta. It was a nice presentation. Now, session is free for the open question.
Harivansh sir, unmute.
Yes.
My screen is gone. I'm not able to see anyone.
Yeah. No, it's okay, sir. Please speak on.
Yeah. Dr. Gupta, I just want to ask you one thing, that you have given a causality hypothesis that the intake of fluoride was responsible for the development of diabetes, and then diabetes was responsible for the development of CKD,
Yes.
right?
Yes.
So which type of study is required to prove this hypothesis?
This is just a simple preliminary study that lead to the hypothesis that that adjacent regions, that the fluoride endemic areas adjacent to Raebareli district, those have a because of the fluoride endemicity, these peoples are having a insulin resistance and these insulin resistance that is already reported in the studies, that insulin resistance lead to the diabetes in the fluoride endemic areas. So this is our hypothesis, and this prolonged diabetes, which has been remain untreated, and because of the improper medication, that leads to the diabetic nephropathy, or for the longer period, if it is been remain untreated, that lead to the CKD. This is our hypothesis.
I'm not asking you the pathogenesis. I'm asking you which type of study you will be able to prove this hypothesis.
So
you did a retrospective study. In the retrospective study, you cannot tell the temporal relationship with the help of a retrospective study. That is what I'm trying to tell you.
Yeah. So we just want to we are just designing an study to measure the concentration of water from the patients, those areas they belong and those they intake, as well as the fluoride concentration in the serum level. Okay, and then we correlate the disease with the kind of fluoride. Is the fluoride elevated concentration in their serum as well as in their water is being related to the onset of disease or not? And this kind of a study we are just want to do in future.
Okay, normally the other question is, normally when we talk of chronic kidney disease, what is the type of anemia which is usually seen? Is it a normocytic hyperchromic anemia or is normocytic normochromic anemia?
Basically, in the papers, it is been reported as a normocytic, but we found that normocytic hypochromic.
So that there could be some other reasons then also, which you might have missed. That is what I want to say. Okay.
This could be a reason.
Thank you. Over to the other co-chairpersons.
So you defined CKD as anything GFR less than 60.
Yes.
While in your classification, if you see, the grade 1 CKD and grade 2 CKD are all above 60. So should we not call them pre-CKD rather than calling them CKD grade 1 and grade 2? Once you define it more less than 60, then how can you call something above 60 a CKD?
Yeah, this is could be acute kidney diseases. We call them the 1 and 2 as a acute, but after 3 or after the GFR with the patients with the GFR less than 60, they are being stage 3 and 4 and 5. Those are being reported. These things are in the literature. they categorize based on
the
this.
very definition of CKD, if you define it as less than 60 GFR, then anything above 60 should not be classified as CKD. It should be either pre-CKD or whatever you can say, but it can't be CKD to define it in terms of CKD.
Yeah, this could be, but if the GFR is more than for around a period of 3 months or more than 3 months, then we call them as means chronic kidney diseases. If it is less than 3 months, means means kidney functionality is compromised for a period of less than 3 months, then we call them as acute kidney diseases. Or
secondly, as correctly pointed out by my co-chairperson Chopra sir, developing a hypothesis, you have to have some scientific thought about it. You know, how did you assume that the fluorosis will lead to diabetes and diabetes will lead to CKD? What is the relationship between the fluorosis and the development of diabetes? I have not heard. I mean, maybe I have not read enough, but I have not really come about the effects of fluorosis on the pancreas causing diabetes.
Yeah, there are.
Maybe some other factor you should have studied, the BMI, maybe the prevalence of obesity. I do not know. There may be so many factors which can be correlated with diabetes, only which can be due to secondary diabetes as a result of pancreatic injury, that we do not know. But linking directly to environmental factor as this thing, maybe if tomorrow you find that somebody is using aluminum utensils may end up with CKD. You do not know.
No,
so
I completely
have something in mind before developing such kind of hypothesis.
Yeah, I completely agree with your consent, but the thing is that we found with the clinicians, we found that the people in the areas of Raebareli district, they are highly diabetic. They are more diabetic, and there are something which is we are looking for some factor which is making them so much diabetic. Their blood sugar levels are quite high, their HbA1c levels are quite high, and this is just a preliminary.
How much was the prevalence of diabetes? I can't hear you.
Okay, maybe he does not know the answer. Okay. We can we go to Dr. Sneha? Sneha, would you like to ask something?
Sir, I think his audio is muted. Dr. Anil Ankit.
No.
Dr. Ankit, can you hear? Okay.
Yeah.
Dr. Ankit, I think your methodology portion should be more clear, because you have not described about, as sir was asking, study design, study population, sample size calculation, consent, ethical consideration. You have not talked about these things.
This is just a retrospective study because we do not have any ethical committees in our newly, new institute. So we are just doing some study just to get an idea what is being, running out in the adjacent regions or in the Raebareli district. So this is just a retrospective study.
But sorry to interrupt you, Dr. Ankit.
Yeah. I haven't mentioned
but for
much more detail
conducting any type of
time
studies,
constraint.
either retrospective or prospective, you should take ethical consideration or consent.
Yeah. I completely agree, but we are just doing our laboratory data and just matching it the things, because we do not having any ethical committee right now. So we are waiting. So when we will have in the future, then we will do some more,
Okay. That simple answer could be in one sentence. That is the limitation.
Yeah, limitations we have.
Yeah,
fine.
Completely admit.
Okay.
Yeah.
Thank you.
Can we go to the next speaker? Hello.
Yes, sir.
But I am not able to see anything on my screen. What has happened?
It was a nice presentation. Our next speaker is Dr. Anuj Kapoor, and his title is Awareness, Knowledge, and Adherence of Medication in Patients with Hypertension from PHC of Katuha.
morning to everyone. Am I audible? Am I audible? Good morning to everyone. I am Dr. Anish Kapoor, demonstrator of GMC Kathua, J&K. A study on my title is a study on awareness and adherence to treatment in patients with hypertension from Primary Health Center of Kathua, J&K. It's a cross-sectional study. Next, please. Hypertension is one of the most important public health problems. It's both treatable and preventable. The most important factor contributing to control in hypertension is adherence to therapy. And therapy does not prescribe PP medication. Adherence with the hypertensive medication is found to be observed at less than 50% of the population. Next, please. My aims and objectives are to evaluate awareness, knowledge, and adherence of medication in patients with hypertension. My methodology part is a hospital-based study, cross-sectional study. Study site is the Rural Health Training Center, Buddhi of Katua. The study period was 2 months, and the study participants are all the hypertensive patients above the age of 40 with or without comorbid condition attending the OPD. Next, please. Study tool is a pre-designed semi-structured questionnaire of developing integrated response of developing healthcare system of rapid population was to use a study tool. The data analysis was descriptive analysis was done by using the MS Excel. Table 1 shows the demographic characteristics of the respondents. My sample size is 163. In the age group, the majority of the age group were taken was 60 70 years, followed by the age group of 51 to 60 years. And the majority were female, that is 65.6%, followed by the male, that is 68, 44.3%. Next, the diagnosis of hypertension is made by the responses we made. The diagnosis of hypertension is majority of the diagnosis is made from the a routine medical checkup. That is 30.7%, followed by the screening program, that is 25.4%. The question is when were you diagnosed with the hypertension? The first time it is the majority of the less than 5 years, that is 30.6%, and followed by the 52.9% more than the 5 years. Another responses would take from how did you come to know about the hypertension. So again here is the majority of the respondents we get to know about the hypertension by a routine medical checkup, that is 30.71%, and followed by the another screening program, that is 25.4%. The second question was where was you first diagnosed having a hypertension? So the people came to us from the first diagnosis at the PHC level, that is 35.94%, which is followed by the secondary care hospital, that is 20.6%, and then the tertiary care hospital. Next, please. The third table shows the management of hypertension. How have you been told by a doctor, nurse, or someone by his healthcare system to control your blood pressure? So we have the maximum majority, 83% of the people are aware from that. But the second question is when do you go for your raise your blood pressure check? So majority of the respondents we have as advised by the doctor, which followed by diagnosis on their visit, that is 38.6%. Another question is to compare to 12 months ago, is your blood pressure. So it feels better. The majority of the population, that 6%, is feels better as compared to when the blood pressure is compared after 12 months ago. Next, please. Table was shows the awareness regarding complication of the hypertension. So we see here the maximum of majority of the respondents are aware from the complication. We have asked are you aware from any complication of hypertension? 77% of the responses we have that the people are aware from the complication of hypertension, where the 40.5% of the population having the history of their relatives having the hypertension, but followed by the last year having 85%. And where is 7.8% population is it related to the hypertension. Next, please. Table 1 shows the medication and adherence. We see the adherence. Have you? The question is asked that have you been prescribed any medication to lower your blood pressure levels? So 93.46 responses we have made. People have prescribed any medication to lower their blood pressure. So 58 points of the respondents have prescribed that medications. And then another question we have asked that if you don't take any new medication regularly, why you take them as directed? So the majority of the respondents have the level that it didn't like as such the medication to take, where it's followed by the some respondents cannot afford the cost of that medication, and some didn't like the effect of the medication. That is 1.9. Next, please. So my conclusion of the study, the main reason of the non-adherence was found to be that patients don't like to take medicines on a regular basis. Important measures could be taken like behavioral change, communication in the community level. Proper IEC activities need to be undertaken at community level to increase the awareness about the benefits of adherence of the medication. Thank you. Thank you.
Yes, ma'am. Thank you so much, Dr. Anush Kapoor. It was a nice presentation. Now, I would like to request our chairpersons if they have any queries or questions, they are free to.
Yeah. So thank you, Dr. Anuj. There are one or two observations as far as your presentation is concerned. In none of your table, you have shown the total, and there are number of tables which are multiple response table. So you have to show the total in each and every table. Number one. Number two, if there is a multiple response table, then you have to say it is a multiple response table, right? That's the way the table is to be presented. Otherwise, it carries no value as far as we are concerned. The second point is that your sampling method is a purposive sampling method.
Yes, sir.
So purposive sampling method means it is a non-probability sampling.
Non-probability, right?
So if it is a non-probability sampling, then your findings cannot be generalized to the population.
Right.
So that you should have written in your limitation, right?
Limitation,
okay.
Right.
So
right.
These are the two comments which I want to give to your presentation. Yes, you have tried nicely to find out about the hypertension, which is a silent killer, and more studies are needed. So over to the next chairperson, Dr. Kushwaha or Dr. Sneha, whatever they want to ask.
Sir, you already brought out the major limitation that was there, and apart from that, as presented, the proportion of people who were diagnosed with hypertension mostly were, for the first time. Some were as part of screening, and then you presented the data on, where all they got diagnosed. Maybe primary health center maximum, then secondary health centers and tertiary. But that is the probability of generally a person reporting to a health facility. The probability of reporting to a primary health center is definitely much more. A person reaching the tertiary health center is that much less. So it does not really convey any message. I don't know how that finding helps you or helps us in giving us the place of diagnosis.
Actually, a study that was conducted at the rural area of our RHCC, Rural Health Training Center of our department. That's exactly. If people approaches to near to PHCs first, the diagnosis, the hypertension, then they having some hypertensive problem, then go to the secondary health center like the PHCs, they are nearby, and then go to the tertiary care center if they have any complication to develop. So I think.
Got it. Okay. Madam, Neha.
Yes, Dr. Anuj, why you selected more than 40 age group persons for your study?
Ma'am, because we have the exclusion criteria like the adult of age less than 25 years and the pediatric population, pregnant and lactating women were excluded. That's it.
Can you more louder? I can't hear you.
Can't hear you properly.
criteria, ma'am, the adults of age less than 25 years and pediatric age group, pregnant and lactating women were excluded from the study. So we taken the
As per
population more than 40 years
NPCDCS
because we
program,
see
which
the
age group should be taken for screening for hypertension or diabetes?
right.
As per NPCDCS program, which age group should be taken for screening for diabetes or hypertension?
Yeah, ma'am, I think it's 30 years.
I
Yes.
can't hear you. Over to Sanjana. Okay,
He
thank
said
you.
30 years, 30 years. So, okay, fine. So we can move. Sanjana,
Yeah.
can we go to the next speaker? Thank you, Dr. Sanjana.
Yes, sir. Thank you so much, Dr. Anuj Kapoor. Our next speaker is Dr. Vandana, and her title is Evaluating Role of Intervention on Cervical Cancer Screening, Knowledge and Attitude of Ashas. Over to you, ma'am. Ma'am, please share your screen.
Am I visible?
No, ma'am, your PPT is not visible.
Okay, I'll try. One minute. Meeting ID बता.
Ma'am, if you are unable to share your screen, then I can share your PPT here.
Thank you, Ms. Akshara.
Or Sanjana, you can go to the next speaker in the meantime.
Okay, sir. I guess.
Yeah.
Ma'am, are you sharing your screen or should I move to the next speaker?
I'm unable for the presentation. I don't know what is the problem.
It's okay, ma'am. After the next speaker,
you can try from your side. You can try from your side.
Wait a minute, ma'am.
Hello,
Yes,
Sanjay.
ma'am.
You can try from your side, please. I
Okay,
can't
ma'am.
share from my side.
Okay, ma'am. Wait a minute. Just wait a minute.
Sanjana, can you try from your side, please? I couldn't.
Yes, ma'am. Just wait a minute. I will share your screen.
Okay. Thank you so much. Okay, thank you so much.
आप व्हाट्सएप पे सर्च करो कर लेता हूँ
Good morning, one and all. Am I audible?
Yes, ma'am, you are audible.
Thank you so much. Good morning, one and all. I'm Dr. Vandana, second year resident from the Department of Community Medicine, Indira Gandhi Medical College, Shimla. Today, I'm presenting Evaluating Role of Intervention on Cervical Cancer, Knowledge and Attitude of ASHAs, a quasi-experimental study. Next slide, please. The cervical cancer is a major cause of mortality in women. In India, it is the second most common cancer in women. ASHA being the interface between the community and health system in India, the knowledge and attitude of ASHA towards cervical cancer screening can grossly influence the community, as the improving the same could help in reducing the impact of cervical cancer. Next, please. The objective. Objective for our study is to assess the knowledge and attitude regarding the cervical cancer among ASHA to determine the effectiveness of the structured teaching program on cervical cancer among ASHA. Next. Material and methodology. This is a classical experimental study done on December 2019. 32 ASHAs from rural health block Sunni district Shimla was taken. Study tool was a self-designed structure, self-administered, pre-tested questionnaire was used for assessing knowledge and attitude. 2-hour intervention was given to the ASHAs through lecture, PowerPoint presentation, and chats. Later on, the post-test was conducted, data analysis using the EpiInfo 7.0. In the result, the mean age of the ASHAs is 39.06 plus minus 6.14 year. Average population under ASHA was 614 plus minus 185, and 62.5% are educated up to metric and higher. 93% are from 7%. 93.7% are lower middle and middle class. Average work experience was 6.34 plus minus 2.36 year. None of them had undergone any screening for CA cervix. The graph is showing the comparison of pre and post-test knowledge of ASHA regarding the CA cervix. Here we can see the good score of the pre-test was one of the participant can achieve the good score. This is the 3% of the overall, and after the post-test, after the intervention, the post-test of the good score is the 78%. That is of 25% can go up to the good score. If we talk about the comparison of pre and post-test attitude of ASHA regarding CA cervix, next slide, please. Thank you so much. Having a positive attitude in the pre-test is in the 13%, present in the 13%. Having a positive attitude in the post-test is equal to 81%. Here we can see that after the 32, 4 ASHAs have a positive attitude toward the CA cervix, and 26 don't have a positive. 26 after the post-test, 26 have a positive attitude toward CA cervix. There is a table. Next slide, please. Showing the knowledge and attitude pre-test post-test score. That is, the knowledge of pre-test score is 2.59, 3.1, and post-test is 12.34 plus minus 1.6. P-value is statistically significant after applying the paired t-test, unpaired t-test. And for the attitude, the pre-test score is 1.84 plus minus 1.3, and post-test score is 5.66 plus minus 1.3, and it is also found to be statistically significant. About the discussion, improvement in the score of the knowledge and attitude in the study was concordant to the similar study conducted by the NSING in the North India. And the pre-test score of knowledge, good and fair, are 21%, which is less than the study done among the ASHA in the Varanasi by Divya Khanna et al. Conclusion: the existing knowledge of ASHA regarding the cervical cancer was inadequate. Increase in knowledge and ASHA regarding CA cervix and screening after providing them knowledge through structured teaching program. Thank you so much.
Thank you so much, ma'am. It was a nice presentation. Now I would like to request our chairperson, if they have any query, they can ask.
Okay. My first question to you is, you selected 32 ASHAs.
Yes, sir.
What was the method of selection?
Sir, the 32, these all are all the ASHA from the Sunni block were taken for this study, because in the Sunni block there is a 32. Yes.
Okay, fine.
Yes.
So it was a purposive sampling?
Yes, sir.
It is a non-probability sampling?
Yes, sir.
So why you have applied a test of significance?
Sir, for the
Listen. When you are using a sampling method which is non-probability, why do you want to find out a probability in that? And how is it valid? This is the mistake which is done by a lot of people. You see, you have to understand what is your sampling method. If your sampling method is not random, right? If the sample method is not based on probability, then why do you want to find out the probability? It has got no value.
Yes, sir.
Because if you are taken 32 ASHA purposely from one particular area, the findings may be limited to those areas. That's all.
Yes, sir.
So I don't want to say anything more than this. Over to
Yes.
Dr. Kushwaha and Dr. Singh.
You measured the knowledge score and you measured the attitude score. How was
Yes,
it
sir.
measured? How was it measured?
So we have a questionnaire and we have divided into the 33% to the 33% of the overall score. 33% is a poor score, 33 to the 66% is a fair score, and more than 66% is a good score.
What
Then,
what
yes,
were
sir.
the questions in attitude? How did
Sir,
you measure it? You
sir,
said attitude towards customer.
Sir, we have a different questions for the attitude that like some of the questions are cervical cancer is one of the most common cancer. Agree or not agree, Likert scale in the basis of the Likert scale, sir.
But this is more to do with knowledge, whether it is a common cancer or not an attitude.
Sir, these are the attitude question. In the knowledge question, we have that. Do you know about the CA cervix where it is present in the in local dialect कि कहाँ होता है और आपको क्या पता है कि screening किस तरह से होती है और screening कहाँ होती है? These are the knowledge.
Okay, good effort anyway for a JR2. I think it's a good effort.
Yes.
But still, you should define your criteria when you are measuring something. How did you
Yes, sir.
measure it? And was it something, a tool which is already existing, or did you devise your own tool? You must define that.
Yes, sir. Yes, sir.
Yes, Dr. Sneha.
I think Dr. Vandana, my co-chairs, has rightly pointed out valid points. In methodology portions, you should put these points, that
Yes,
how
sir.
you
Yes, sir.
measured and how you have took those populations. No questions from my side. Thank you.
Thank you, ma'am. Thank you, ma'am.
Next.
Can we go to the next speaker?
Yes, sir.
Yes.
So our next speaker was Nidhi Booth, but she is not presenting. So we are moving to our next speaker, Dr. B. Praful Kumar, and his title is Prevalence of Hypertension and Associated Risk Factor of Hypertension.
This is the last speaker.
Yes, sir, last speaker.
Okay.
And sir, just a little reminder, sir, you need to fill the Google form, and I have shared one agenda.
We are doing that. We are doing that.
Okay, sir. Thank you, sir. Over to you, sir, Dr. Praful Kumar. Please share your
Hello.
screen.
Yeah. Hello.
Yeah.
You are able to see, sir?
No, we are not able to see your screen. Yeah, no, maybe.
Hello.
Yeah.
Hello.
You are audible.
Yeah. Good morning,
Yes,
sir.
you are audible and your PPTs are not visible, sir. Your PPT is not visible, sir.
Hello.
Yes, sir.
Yeah. Able to see my slide?
No, sir, not yet. Sir, if you are having any problem, then I can share your slides over here.
Yes, ma'am. Please.
Okay, sir. Please stop sharing, sir.
Okay. Hello.
Yes, sir. You may start now.
Hello. Good morning, all. Myself, Dr. Praful, final year postgraduate from Community Medicine Department. My topic for presentation is on hypertension, the prevalence of hypertension and associated risk factors in a rural population, a cross-sectional study. So we know that raised blood pressure is a major risk factor for coronary artery disease as well as stroke, which is responsible for majority of premature deaths and disability. And according to JNC7, systolic blood pressure more than or equal to 140 mm of HG and diastolic blood pressure more than or equal to 90 mm is considered as hypertension. Next slide, ma'am. Hello. Hello. Ma'am, next slide.
Yes, sir. I am done.
So globally, 13.5% of premature deaths and 54% of stroke and 40% of ischemic heart disease are attributed to the high blood pressure. So high systolic blood pressure and smoking were the leading risk factors contributing to dialysis in 2016. And hypertension itself is an independent risk factor for cardiovascular and cerebrovascular disease. So hypertension is an important health problem in both rural and urban areas of India, which is accounting for 10.8% of all deaths and 4.6% of dialysis in India. So my objective of study is to estimate the prevalence of hypertension among the 35 to 14 years old rural population and to estimate the prevalence of risk factors which are associated with hypertension among them. So the methodology include the study setting is a rural field practice area, which is a community-based cross-section study, and the study population include 35 to 49 years old population. And my sampling technique is systematic random sampling, and the sample size is 240. My study tool is a modified pre-tested WHO steps approach to chronic disease risk factor surveillance, measuring tape and weighing machine. And the data was analyzed using SPSS version 19 and descriptive statistics. Frequency and percentage were calculated and chi-square test was applied, and a p less than 0.05 was considered as significant. Coming to the results, table 1, the study population majorly composed of females were 55.4%, and the majority of them were in the age group of 45 to 49 is 37.5%, and 47.1% have actually finished their schooling, and 58.6% were in unskilled occupation, and 55.4% were in the lower class. And among them, hypertension was found to be 21.5% among males, and females it is 13.5%. So overall, hypertension prevalence among the study population was 17.01%. And coming to the risk factors, the people who are actually hypertensive, among the 38 were having a smoking habit, and those who are not hypertensive, only 3 were having smoking. And alcohol is found in 35% of hypertensive people and 6 in non-hypertensive people. And physical activity was there among 31 out of in hypertension positive, whereas there is no physical activity among the 10 non-hypertensives. And the obesity was found in 37 members in hypertensive people, and and in non-hypertensive obesity was not there. So coming to the, calculating their p-square, the p-square was p-value was significant with the smoking, alcohol, and obesity less than 0.05. So coming to my conclusions, in the present study, prevalence of hypertension is 17.01% in 35 to 14 years of study population, of which the males are 23 and females are 18 number. And the risk factors associated with hypertension, smoking, alcohol consumption, obesity are statistically significant, which is p less than 0.05. And this can be concluded that the prevalence of hypertension high even in rural settings, which can increase the risk of non-communicable disease burden. So the recommendations is to improve the surveillance system and implementation of screening programs for early detection of hypertension at community level, and at individual level, interventions like weight reduction, physical activity, reduction in tobacco and alcohol consumption can be done. And the limitation of my study is stress, which is an important risk factor in hypertension, and along with the salt intake and family history could have been given better results. And And the other limitation is I will include on the study population age of 35 to 49 years. Thank you.
Thank you so much, Dr. B. Praful Kumar. It was a nice presentation. I would like to request our chairperson to share their views. Over to you, sir and ma'am. Dr. Harivansh Chopra, sir, your voice is not audible.
Okay, okay. I think I'm audible now.
Yes, sir.
Yes, sir.
Yeah, thank you very much, Dr. Praful. You have done, you have tried to do a right kind of a study, but your sample size was 240. What, how much incidence of hypertension have you taken?
Sir, I've taken the overall hypertension in India, which is 30%.
30%.
Yes, sir.
And
at allowable error was 20%. So the sample size arrived as was 233. So I rounded it off to 240, sir.
So why you have taken this 20% allowable error? To reduce the sample size.
Yes, sir.
Okay, okay. That is fine. At least you must know what you are doing. And I'm happy at least you know what you are doing. That is one aspect.
Sir.
The other aspect is you found out 3 significant risk factors. These were smoking,
alcohol,
and alcohol.
Yes, sir.
So, could you have applied another test to find out which one factor is responsible or is more associated with hypertension? Any other test which you could have applied?
Maybe univariate analysis.
Univariate analysis and chi-square is one and same thing. Does not tell us anything much more than that. My part is this: if you have applied the multiple logistic regression amongst all three, then your study would have been in much better shape, right? But at least I'm happy. At least one study is I found only one study which is which I can say is fulfilling the criteria of carrying out a study. But yes, you pointed out the limitation again, 35. When you are using steps approach again, what is the recommendation? As my co-chair, Dr. Sneha, asked from the previous speaker also, above the age of 30 years, you have to do that. And you put a limitation 35 to 49. That I can understand why you limited that. When you are doing a study in the field, why you are limiting to the population, right?
Yes, sir.
So,
yes, sir.
In steps approach, there are other factors which you could have studied, but you have not done. So thank you very much. That's a good attempt, but yes, try to improve further. Right. That is.
Yes, sir.
Over to Dr. Kushwaha.
Thank you, sir. Two important risk factors we have left out. One was family history of hypertension, whether their parents were hypertensive or not.
Yes, sir.
Which is again a very, very risk factor. Second is salt intake. We have not mentioned at all anything about salt intake.
Yes, sir. That is because in the rural population, so I thought I could not exactly assess whether they're taking more than 5 grams of salt or less than 5 grams of salt.
No, you have not mentioned anything about that. Whether you attempted, whether you did not attempt, we did not know. So actually, these are important risk factors which have to be mentioned once you're talking about hypertension. You cannot leave those things. You know, maybe it is much more important than even alcohol or possibly any other risk factor like that. So that is one. And secondly, how did you measure how did you diagnose hypertension?
Sir, I measured blood pressure, sir. Three consecutive readings with 10 minutes gap in between in a sitting posture.
Okay.
So I've taken mean of the 2 readings.
Okay, and once it is found to be elevated, you declared him hypertensive.
I've considered as hypertension, and then I further asked about the risk factors, what all is habits and all.
I think you should. I think WHO does not say that one single reading like that or two readings like that will. You possibly should measure the same people again after a gap of few days, maybe 2 days, 3 days, and if found consistently, then you only declare them to be hypertensive. I think WHO guidelines you can read about that. I don't know really. I think I remember having done that study some time ago, and we needed to measure twice at least on the 2 different days. And second thing is classification of hypertension. We just classified hypertension absent and hypertension present. So it should
Yes,
not
sir.
be like that. It should be either hypertensive and normotensive. Actually, there's another third category which you should have also defined, that is known as pre-hypertensive.
Pre-hypertension.
Pre-hypertensive and normotensive. That is how it should be. That is how the WHO tells us to do. So possibly that would have added better things to your findings. Dr. Sneha, please.
Dr. Praful, which type of classification of hypertension you have used in your study?
Ma'am, JNC 7.
Yeah, you should mention that. And one more point, in your study, you found results significant with 3 of the determinants of hypertension, that is alcohol, smoking, and obesity. But in
Yes, ma'am.
recommendation, you also recommended about physical activity. Always remember that results should be, your recommendation should be based on your results only.
Yes.
Okay?
Yes, ma'am.
Theoretical portion is another thing, but during your study, recommendation should be based on your results only. Okay?
Yes, ma'am. Yes, ma'am.
Okay. Thank you. Over to Sanjay.
Thank you, ma'am.
Okay, thank you. Thank you so much. I would like to give my gratitude to the organizers for giving us this opportunity to chair this session. And I would like to thank my co-chairs who have wonderfully conducted this session and pointed out all the deficiencies which were there in the various presentations. And for the participant, I would like to say that we are not here to criticize you. We ask these questions so that you can further improve upon. You have got a long way to go. And if you learn in a right way, then you will be doing the right kind of things, and maybe you will be able to make a change in public health in India. Thank you so very much. From my end, that is all I want to say. So goodbye to all co-chairpersons and the organizers. Thank you.
Thank you, sir.
Thank you, sir. It was a privileged moment for you, just seniors, respected seniors, to share the co-chairmanship with you people. And also, I want to give thank you to Eficon, Sanjana, and all the participants have just presented very well. Thank you all.
Thank you, everyone.
Before wrapping the session, I would like to express my sincere thank you to each and every one of you for being here today with us. And we are very pleased to be able to welcome you all in this Eficon 2020. And a very warm thanks to our chairpersons who gave their time to us. And so now we are concluding our session here. Have a good day. Thank you.
Good day. Good day.
Dr. Anirudh, are you there?
Hello, ma'am.
Hello, I'm there.
Hello,
I'm
ma'am.
there. Yes, I'm there.
Yes, ma'am.
Uh-huh.
Just a second. I'm just trying to make sure everyone else is on board. I'm actually awaiting Dr. Rita Devi, and I'm trying to contact her for just a second. Actually,
Okay.
she hasn't been able to join the session, nor is she picking up my phone call. I'll just wait for her for a couple more minutes, and then I think we'll begin. Sincere apologies to everyone present here. There seem to be some technical problems with some of our chairpersons. We're just awaiting one of them to join currently, and we'll be beginning as soon as possible.
Session in the Eficon. I am chairing a session in Eficon. Please message me.
All right. A very good morning to one and all present here. And welcome to the morning session of the oral session on primary healthcare at Eficon 2020, the National Conference of Epidemiological Foundation of India. It's my honor to introduce the eminent chairperson that we have today. We have firstly, Dr. Leena Roy, who is the additional medical superintendent in the Northern Railway Divisional Railway Hospital in Moradabad, Uttar Pradesh. She has an MD in clinical biochemistry, and her core competencies include clinical biochemistry, clinical epidemiology. She's a health administrator and superintendent, drug and logistics, procurement and management. We welcome you, ma'am.
Thank you, Anirudh. Thank you.
We also have with us Dr. Shashank Gotarkar, who is the assistant professor at the Department of Community Medicine at the JLN Medical College at Wardha. We welcome you, sir.
Thank you so much. Can you hear my voice?
Absolutely, sir. We can hear your voice.
Okay. Thank you so much for this brief introduction.
Most welcome, sir. And our third chairperson for this session is Dr. Rita Devi, who has done a PhD in nursing and is an assistant professor and post coordinator under IGNU. We welcome you, ma'am.
Thank you. Thank you.
We will now be beginning with our first speaker for the day. I request Dr. Sajad Hussain Bhatt of registration number 326 to begin his session. And I request him to begin sharing his slides if possible. He will be speaking on the topic to study the purchase process, lead time, and bottlenecks in purchase of drugs or items in drugs and PHA.
Anirudh, just an intrusion. I was inquiring about the registration numbers. I could not find them. Would you let us know or let the speakers tell about it right in the beginning?
Ma'am, otherwise you can ask me, I will tell you. Okay. As I'm introducing him, I've said his number is 326.
Okay, okay. Thank you.
Just a second.
Anirudh?
Yes, sir.
I have not received any evaluation sheet. How to evaluate?
Your evaluation sheet is present on WhatsApp, sir. I've sent it to you in the morning today. If you can check once more. In that, you have to add the person's, each speaker's name and his registration number. For example,
okay.
the first speaker for today is Dr. Sajid.
Fine.
In that, his registration number is 326.
Yeah.
Dr. Sajid, are you with us at the moment? All right. So I will start with the next speaker until we wait for Dr. Sajid. Is Dr. Urusa present here? Okay. So the first speaker for today is Dr. Sajid.
Fine.
That registration number is 326.
Yeah.
Okay. We will start with Dr. Darakshan then. Her registration number is 308. 308.
Yeah. Good morning. I'm here.
Good morning, ma'am. You heard her and her title. I request you, ma'am, to begin sharing your screen.
All right.
She will be speaking on the topic knowledge and attitude regarding biomedical waste management among healthcare workers. Over to you, ma'am.
Little bit information about you. Are you a medical student or a PG? Or
I'll start with that, ma'am. Yes, I am an assistant professor at Government Medical College, Baramulla.
Okay.
Please let me know when I can start, Dr. Anirudh, please.
You're most welcome to begin, ma'am.
All right, thank you. Good morning, one and all. I am Dr. Darakshan from the Department of Community Medicine, GMC Baramulla, and I'm going to present my study on knowledge and attitude regarding biomedical waste management among healthcare workers in Rural Health Center, District Bandipur of Kashmir. Biomedical waste is defined as the waste that is generated during diagnosis, treatment, or immunization of humans or animals, or in the research activities pertaining thereto, or in the production and testing of biologicals. 75 to 90% of the waste is considered to be non-hazardous, while 10 to 25% carries a high potential for infection and injury. Among the most dreaded ones are hepatitis B, C, and HIV/AIDS. In India, I'm sorry, I can't switch to the
I
next
can't put the
slide.
timer.
Just a second. There's something wrong with the video. I'm not able to switch my slides.
Ma'am, since you're sharing the screen, the possibility to change the slides would be only with you, ma'am.
I've shared my screen. Can you see the slides?
Yes, ma'am. We're on introduction at the moment.
Yeah, right. All right, the second slide. In India, even after 20 years of making of biomedical waste management rules, it's a serious issue for hospital authorities, environment and law enforcing agencies, media, and the general public. It has been seen that there's a poor hospital waste management situation almost everywhere. This indicates an urgent need to assess the knowledge and attitude of healthcare workers, which in turn determines their behavior. Coming to the methodology, the objective of our study was to assess the knowledge and attitude regarding healthcare waste management among healthcare workers. This study was done among healthcare workers for a period of 1 month working in Rural Health Center of District Bandipora of Kashmir, which is a rural field practice area of Sher-e Kashmir Institute of Medical Sciences. It was a cross-sectional descriptive study, and the study subjects who had been working in healthcare facilities for at least 1 year were included in the study. As such, 108 participants participated in the study. Coming to results, this slide shows the general characteristics of the study participants. It was seen that most of the study participants belonged to more than 35 years of age, followed by 30 to 35 years, 25 to 30, and 20 to 25 years of age group. 55.6% of our study participants were females. We categorized the study participants into 5 strata, with 22.2% of them being doctors, 18.5% pharmacists, 11.1% being nurses, 33.3% were female multipurpose health workers or nursing orderlies, and 14.8% were housekeeping staff. Most of the study participants had a work experience of more than 6 years. Coming to the knowledge, it was seen that most of the participants, like all, had correct knowledge regarding the type of hospital waste, types of waste associated with health hazards. The waste management is a legal necessity, and color-coded bins are required in the health facility. Majority of them had correct knowledge regarding hospital waste management as a health risk, who should be responsible for waste segregation, polythene bags used for the lining of bins, and color coding of bags and emptying of waste bins. However, none was aware about how the hospital waste is finally disposed and about the regulatory authority concerned with biomedical waste management. The attitude of the healthcare workers was assessed on a 3-point Likert scale, and it was seen that all of them agreed that biomedical waste must be safely managed. 66.7% considered waste management their responsibility, and most of them believed that waste management is possible even in rural areas and if patients are poor and illiterate. Most of them did not consider biomedical waste as an extra work burden or an unnecessary expenditure. It was seen that that a considerable proportion of the healthcare workers lacked correct knowledge and had a negative attitude towards it, which would reflect in their practices and pose a risk to themselves and others. Thus, there's a need for rigorous training programs of healthcare workers on biomedical waste management and monitoring of the same. I would like to conclude by quoting K. Park, "Let the waste of the sick not contaminate the lives of the healthy." Thank you.
It was a very good presentation.
Thank you, sir.
May I know your registration number?
Yeah, it's 308, sir.
Okay. So it is a nice presentation.
Thank you.
Any other chairperson wants to add something?
Dr. Roy here. Very well done.
Thank you,
and how did you, madam, you classify this attitude based on what questionnaire? Was it on a questionnaire level?
Yes, ma'am. It was a self-administered questionnaire which we designed based on the previous studies that had been conducted regarding the same.
All right. Biological waste management is really a headache for all hospital managers.
True,
in fact, I'm very happy that you've included the doctors.
Yes.
We think it is healthcare workers and the Safai Walas come, But no, it is ours. Unless
Yes,
we have
ma'am.
that knowledge, how can we disseminate the knowledge to the lower downs?
Yes, ma'am. Right, ma'am. Yes, ma'am.
And your study is based on Kashmir, isn't it?
Yes, ma'am.
Definitely. As a manager, we find out that we give this kind of dumps to we outsource it, and we
Yes,
should
ma'am.
periodically examine the what should I say, the licenses of this outsourced parties, because
Exactly.
usually they do not have a proper license
Mm-hmm.
and they go and dump it anywhere they like. That
Yes,
is a
ma'am.
gross mistake that we should never overlook.
Yes,
And
ma'am.
from time to time, we should call them in, check their documents. Do you have
Exactly,
the
ma'am.
system to do that? Do you have the
Not
system?
exactly, ma'am. Not in Kashmir. We do not have a proper system in place. That is why it's a problem. You can see biomedical waste syringes and needles lying down everywhere with the
Yes.
general municipal waste. So it is really a problem, and people are really ignorant about it right now.
Yeah, we need to segregate these things. In Maharashtra, it is being implemented on large scale in every hospital, that biomedical waste rules are there in each hospitals.
True, very true. And it's a very now that with COVID thing, they're very particular. Those infected material with the COVID thing is handled differently, and different packages and different
Yes.
containers, and the
Yes.
other ones.
Mhm.
So we have been very particular that this should go at the right place, destroyed in the right way, so that not only are we treating, we are preventing others too. As according to Park, we are supposed to not to infect others with our unhealthy things, isn't it?
Exactly,
That way
ma'am.
we are
Yes.
limiting, and that way we are preventing more spread of the infection.
Exactly.
Nice
Ma'am.
work done. Nice
Thank
work.
you. Thank you, ma'am. Thank you, ma'am.
The rest of the Madam Rita or
Yeah,
Dr.
I am there,
Ma'am,
Dr. Rita.
ma'am, I request you, ma'am. I think we will wrap up this presentation. We have actually a time limit around 5 minutes, which can be extended to at the most 7 minutes for each speaker. Because otherwise, we'll overshoot the time.
Right.
So I think
Right.
we seem to have overshot this time as well for the speaker for Dr. Direction. Thank you so much, Dr. Direction and Chairperson.
Thank you. Thank you, Anirudh. Thanks a lot.
I request you to stop sharing your screen, Dr.
Okay.
Direction, so that
Okay.
we can begin with the next speaker.
Yeah.
Thank you so much. I request Dr. Sajid Hussain Bhatt to share his screen. He is registration number 326, respected chairperson. He will be presenting his paper on to study the purchase process, lead time, and bottlenecks in purchase of drugs or items in drugs and DHA.
Good morning, sir. Good morning to all panelists. I'm Dr. Sajid Hussain. Am I audible?
Absolutely, sir.
Yes,
Please
you
begin.
are.
Sir, the topic of my presentation is to study the purchase of drugs, items, and bottlenecks and lead time in the drug and pharmacy department of a tertiary care hospital. Drug and pharmacy department is one of the most important supportive services of a hospital. And the main objective of the purchase department can be enumerated simply by the function will be right to broker the items at right quality, right quantity, right price, right source, at right place at the right time. The lead time is the time required to acquire the supplies in any hospital. The lead time is divided into two parts. It is the internal lead time and external lead time. The internal lead time is required to complete the institutional formalities within the hospital. And the external lead time can be defined from the time the supply order is placed up to the acquisition of the supplies. It is easier to reduce the internal lead time because it is within the hands of the people within the hospital. External lead time can also be reduced by some measures like timely reminder, judicious supplies, and penalty for delayed supplies. The present study was carried out in the Drug and Pharmacy Department of Sikkim Mills. The present study was a retrospective one carried for a period of 1 month, and in which all the drugs that were purchased during the year 2019 were studied. The purchase process included projection of the requirement by user department by verification by the concerned person in the pharmacy department, transfer of the requirement to the purchase department, placement of supply order, and the receipt of supplies. It was observed that for majority of the items, the internal lead time was 20 to 35 days, and it was for about 60% of the drugs. The external lead time that was calculated was, for majority of the drugs, it was 20 to 40 days. That was around also 60%. It was observed that the average internal lead time was 27 days and average external lead time was 34 days. The internal lead time was mainly due to the calculation of demand, projection of demand to the purchase department, completion of all formalities, and issuance of supply order. The reasons for increase in external lead time were problematic suppliers, increased demand, product in the market, shortage of product in the market, road blockade, unforeseen circumstances like strikes, etc. To conclude, the lead time is important. It can be reduced by certain measures. Although this process has been streamlined in our hospital by we tender our drugs every 2 years, and we produce a rate contract for these drugs, and that is valid for 2 years. So unnecessary delays in the tendering process are avoided. That process has been streamlined, but it can be still be reduced by certain inventory control measures using modern techniques of procurement and avoiding red tapeism, etc. Thank you, sir.
Thank you, sir. I request the chairpersons to ask any questions if they have regarding his presentation.
Yeah, it was a very good presentation.
Thank you, sir.
Only one question, simple. What do you mean by retrospective study?
Actually, it was carried out in the previous year. This drugs that were purchased during in the year of 2019.
Okay.
It was the study was conducted in the year of 2020, and it was the drugs that were purchased during the year 2019 were taken into the study. That is
okay. Thank you. And what is your registration number?
Sir, my registration number is 326.
326. Okay. Thank you.
Thank you, sir.
In fact, it is not related with the study, but I'd like to ask Dr. Sajad, you have been going through the study. I'll not take much time. Do you have an annual medical, we call it AMI, indent? Based on that, how much you have procured from the supplier and how much you have not? Do you have that? No.
No, ma'am, we don't have that in our hospital.
That is a very good system. Then we can, from time to time, we can keep on telling them you have not been a good supplier, and then we can switch on to the next suppliers and things like that. You know?
Exactly, ma'am. Actually, we put a penalty clause in the tender process. If the supplier fails to provide the drugs within the suitability time, that is 42 days, we can penalize the supplier. We keep that clause in the tender
Thank you.
process.
It was a good presentation.
Thank you, ma'am. Thank you.
Thank you so much, Dr. Sajid.
Thank you, sir.
I now request Dr. Nazuk Razdan. Dr. Nazuk Razdan, if you're present, kindly unmute yourself and share your screen.
And his number?
Nazuk Razdan's number is 217.
Yes, sir. Am I audible, sir?
Yes, sir. Yes, ma'am, you're audible. She is registration number 217. And she will be speaking on the topic safe drinking water and hygiene facilities utilization in rural households of the Kathua district. Over to you, ma'am. Request you to start sharing your screen.
Yes. Is it visible? Am I able to share the screen with you all?
Absolutely, ma'am. Absolutely. We can see and hear you.
Okay. A very good afternoon to everybody. I'm Dr. Nazuk Razan. I'm the demonstrator at Government Medical College, Kathua, Jammu and Kashmir. My registration number is 217. I'll be talking about the topic safe drinking water and hygiene facilities utilization in the rural households of Kathua district, which is a cross-sectional study. Firstly, the introduction. The collective term WASH is for water, sanitation and hygiene, which plays an important role in decreasing the morbidity and the mortality associated with the poor WASH practices. These are living with the improvement of the water and sanitation in association with the change in hygiene behavior results in the maximum effects on the health of the people because of the variety of disease conditions like diarrhea, intestinal infections, and skin diseases, etc. It's a precondition to assess the water, sanitation, and hygiene for people so that they can acquire better health and get benefits from all the economic development. Due to the lack of this wash practices, every day approximately 800 children die because of these preventable diseases. The global estimation about this wash practice is around 666 million people who are not able to use the safe drinking water facilities because of the unavailability of the wash hygiene. According to the SDG 6, it is to ensure sanitation and availability of water, that is adequate accessibility and availability from the three core components of water, sanitation and practices. Now coming over to the material and methods, it's a present observation community-based cross-sectional study was conducted over a period of 2 months, that is from November 19 till December 19 in the households of the rural population of Rural Health Training Center, Buddhi, which is a field practicing area of Department of Community Medicine in Government Medical College, Kathua. The information gathered was from the head of the households as well as from the other household members. Around 50% of the population was selected randomly.
फिर आया अब कुछ उरूसा फारूक, लेकिन मेरा है बट
around 50% of the population was selected randomly by lottery method, that is 1260, and consisted of 480 households. But at the time of the study, only 400 households were accessed because of the non-availability of the household members, and some households were logged at the time of the interview. Except the absence and household members logged households, there were no other exclusion criteria in this study. The household members were then interviewed after obtaining an informed consent from them. WHO and UNICEF standard questionnaires for WASH practices were used to collect information about the WASH practices. The questionnaire include core questions on drinking water and sanitation for the households. The data was entered in Microsoft Excel and analyzed in the form of numbers in percentages. Now getting over to the results. In our study, it revealed that nearly 72% of the families were joint type of families, and most of these families were headed by male members, that is 82%. And out of these head of the families, only 65% of them were literates. Majority of the adult women, that is 60%, spend around more than 20% of their time in fetching the water from the household in one trip. 61% or 61.5% of the household use different methods to treat water for drinking purposes. And out of those 61%, 38.5% used boiling as the preferred method of water treatment. In case of sanitation facilities, around 72% of the household members used pit latrines and open pits for their daily use. And about 34.48% of the household dispose of the children's feces into the toilets and latrines. Now coming over to the discussion, the supply of the drinking water along with the provision of the safe drinking water and sanitation facilities is one of the important elements of the primary health care. The indicator of the improved drinking water is good, that is 68.5% as compared to the rest of the studies. In our study, only 38.5% of the household use the boiled method as their treatment for drinking safe water, as it is safe as compared to rest of the studies when 90% of the household had habit of boiling the drinking water. The best method for water disinfection at household level is chlorination and candle filtration, which improves the water quality. And about 59.5% of the household members used improved sanitation facility. In the end, let's conclude it like, in spite of the better indicators of improved drinking water sources, rural population are still lacking in getting connections of the piped water supply and lacking in basic sanitary practices. It results in increase of cases of diarrhea, which are due to the fecal contamination of the water sources. Local administrations need to accelerate the process of supplying piped water connections to the unreserved to improve their drinking water resources and also increase the access to the basic sanitation and services of the household level. Thank you.
Thank you, ma'am. Request the chairpersons to ask any relevant questions to the speaker.
Dr. Shashank may ask about their study methodology and everything.
Yeah, I have. Uh, can you hear my voice?
Yes, yes, sir, I can.
Okay, so what is the methodology we have used?
Sir, I've used the lottery method in this type of the study.
Okay, can you show me the slide of methodology?
Yes, sir.
So what are the uh, what are the drawbacks or what are the lag points you have been faced while taking this by doing this study? What are the कुछ कमियां आई थी क्या तुमको या फिर कुछ गड़बड़ हुई थी क्या कुछ प्रॉब्लम्स हुए थे?
It was a random lottery method, so we couldn't get the maximum households available there.
Yeah, definitely.
So we definitely got hindered because of those things. So
Okay.
instead of doing a lot, we could have used some other methods like a randomized control method or something, so that we can do it in a better way, so that we could cover maximum number of the households in the rural population, rather than doing a lottery method.
Yeah, that means this is your limitation.
Yes, sir. Definitely.
Yeah, so I would suggest that you should publish this article, publish this work in a good Scopus or Web of Science journal.
Yes, sir.
And one more a simple question: what is difference between SDG and MDG?
So the MDGs are the Millennium Development Goals, which were used earlier, and now we are following the Sustainable Development Goals, where we have all the health issues, health-related topics are covered in under the SDG number 6.
Okay. So thank you, and next chairperson can ask the question.
Rita ma'am, if you have any questions, or if Leena ma'am have any questions, otherwise we can move on to the next speaker in case there are none.
In case Rita doesn't talk, then we can move on because we can save time that way.
Absolutely, ma'am. Absolutely.
Yeah, it was a good presentation. You can move on, please.
Thank you so much, everyone. Thank you so much.
Thank you so much, respected chairpersons and Dr. Nazar. We will now be moving on to our next speaker, Dr. Sonika Sangra. I request Dr. Nazar to stop sharing her screen if possible, and Dr. Sonika Sangra to begin sharing her screen. Dr. Sonika Sangra, with registration number 235, will be speaking on the title Assessment of Indicators on Drinking Water, Sanitation and Hygiene Practices at the Rural Schools of Kathua. Over to you, ma'am.
My screen is visible. Hello, doctor.
Hello, ma'am.
Dr. Anirudh, my screen is visible.
Your screen is visible, ma'am, but your presentation isn't quite visible at the moment.
I am Dr. Sonika Sangra from Assistant Professor, Department of Community Medicine. My topic is assessment of indicators on drinking water, sanitation, hygiene practices from the rural schools of Kachua. Introduction of my part is.
Excuse me, ma'am.
Water supply. Yes.
Sonika, ma'am, your presentation cannot be quite seen actually at the moment. Do you want me to share it for you instead?
Okay. Please.
unless you can share it in some other particular way. Um, just a second.
Now visible?
It is not visible at the moment right now, ma'am. Just a second. Is it visible? All right. Just a second. I will share my screen currently.
Okay, thank you.
All right. Ma'am, is the screen visible to everybody?
Yes, yes.
Sonika, ma'am, you can ask me to change the
Can
slides, and
start?
accordingly, I will change slides.
Okay, thank you. Safe and adequate water supply and sanitation in schools are prerequisites for right to basic education for school children. An estimated 1.9 billion school days could be gained if the MDG related to safe water supply and sanitation are achieved and the incidence of diarrhea illness is reduced. The provision of wash facilities has been wash intervention aims to prevent and control transmission of disease, bacteria, viruses, and parasites. Next slide. Many policies and programs to promote wash as the pride of the nation, Swachh Bharat Mission was initiated by the government in engaging the public-private partnership. Wash interventions such as safe water storage for potable water, latrines for sanitation, and soap for hygiene, bath, and hand washing. My objective of the study to assess the indicators of wash in schools falling under the Rural Health Training Center, Budhi, which is under the Department of Community Medicine, GMC, Kachua. Now comes to the material methodology. Next slide. My study is the cross-sectional descriptive study. It takes the duration of the 2 months, that is the December 2019 and January to 2020. It was done in the field practice area of GMC Kachua, Budhi. The total number of schools under the jurisdiction of my center are 36. So the interview of the head of the school was done using the WHO and UNICEF standardized questionnaire for WASH practices. The questionnaire, which includes the core and expanded questions on drinking water, sanitation, and hygiene practices. Core questions on drinking water. Results. Next slide. Next slide. The questions are the main source of drinking water, which is provided by the school. The maximum schools, approximately 94.44% of the schools provided the water through the piped water supply. But some 5.55% of the schools carrying the cart or the tanker truck are available when the source are not from the piped water supply not available. And 88.88% of the drinking water from the schools are safe for you. Now come to the second question, which is the sanitation supply. The students use the flush at the poor flush toilets in 75% of cases. Pit latrines with slab, they are using in 13.88% of cases. And some of the schools are using pit latrines without slab. But maximum schools, approximately all the schools are having the toilets and latrines separate for the girls and the boys. Next, the hygiene part, there are hand washing facilities at the school. There are only 50.33% of hand washing facilities at the school, but only 27.77% of the schools are having the water and the soap facilities, with only 52.77% have only water only, with not provided the soap, and 13.80% provided with soap only. Next, these are the indicators. Next slide. Next slide. These are the indicators of WASH. Proportion of schools, only 94.44% of the schools are having the basic drinking water, improved drinking water facilities, with 88.88% of schools are having the single-sex basic sanitation facilities, and with only 27.77% of schools having the proportion of schools with basic hand washing facilities. There are also, because of the less time, there are also expanded questions are also available regarding the menstrual hygiene, disposal, and the separate toilets for the girls. Now the discussion part, many studies, discussion next slide. Next slide, please. Many studies have shown that lack of sanitation has a negative impact on the education, participation, and livelihood of girls and women. In an area of the world where open defecation and fecal-related illnesses are common, wash facilities are critical for human health. Latrines eliminated open defecation at all the schools, and submersible pumps provided access to running water. Conclusion. Next slide. Next slide. An effectively and efficiently implemented wash in schools will lead to students who are healthier, perform better in schools, and positively influence hygiene practices in their homes among the family members. Water and sanitation play a crucial role in curbing the transmission of diarrheal diseases. Due to the poor quality of the drinking water supply and sanitation options, waterborne diseases erupt every year during the summer and the rainy seasons. Addressing the wash needs of the women and children can provide direct and indirect health, education, and economic benefits to the entire community. A successful wash program in schools would include hygiene education programs, student-led water committees, clean water tanks, hand washing stations, disposable female sanitary napkins, and functional latrines and urinals. Thank you.
Thank you. Thank you for this presentation. So what is your registration number? I was not able to hear it properly.
Okay, sir, 235.
Pardon?
Sir, 235.
235.
235, Dr. Sonika Sangra.
Okay, it was a very good presentation about the wash,
Thank you,
and
sir.
Dr. Rita ma'am
Yeah.
would like
Yeah.
to add.
Yeah, I would like to ask you about you told single sex based sanitation. What do you mean by that? Means they have only
Yes.
toilet for one kind of gender or not for other?
Yes, sir. Yes, ma'am. Only for in some of the schools having only boys' toilet are there, girls' toilet not provided.
Yeah.
Girls' toilet there, boys' toilets are not provided.
Okay.
And even the disposal of menstrual hygiene products,
Yes,
they're
it
not
is a
available there.
yeah.
Yes, these
And
are the
what is this student led water committee? What does it do there in that area? Student led water committee.
They even didn't know about the basic program. So we are now hiring some committees so that proper care of the sanitation and hygiene practices will be available at the school level. So we recommend the medical officers, including the teachers, to improve such conditions in that schools.
Thank you. Thank you.
Sonika, just another question for you. You have brought out a nice thing that you have WHO-based questionnaires, and I was seeing the soap, water, there's such low percentage, 2%, 5%. Definitely your study should be published so that the health school authorities and the health authorities should be more conscious about this. Nice observation.
Yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you.
Thank you so much, ma'am.
Anirudh, we can go on.
Yes, ma'am. We
Thank
can
you.
now move on to the next
Okay.
presentation. I request Dr. Ashutosh Saini, registration number 203, to present his presentation and present his screen as well, to share his screen. Dr. Ashutosh, if you're there. Dr. Ashutosh? Since Dr. Ashutosh doesn't seem to be responding, I request Dr. Anshul Rajput with registration number with registration number 131.
He's on the.
Yeah, this is Dr. Anshul Rajput.
Hi. Yes, kindly share your screen to present your
Yes,
oral
sir.
presentation.
His number, please.
His registration number
Anshul.
is 131. And he will be speaking on the title, An Assessment of Knowledge and Skills of Cold Chain Handlers in Government Health Facilities.
Yes, sir. Sir, is my screen visible?
Absolutely, sir.
It is.
Okay.
Your
Okay.
time has started, sir.
My study is on assessment of knowledge and. Sorry, sir, 1 minute. My study is on assessment of knowledge and skills of cold chain handlers in government health facilities. Okay. Immunization is one of the most cost-effective measures to prevent childhood diseases. Vaccines are sensitive biological products and their potency can diminish irreversibly when exposed to inappropriate temperatures. The vaccines are highly temperature sensitive and vaccines potency once lost cannot be restored. Method. A cross-sectional study was conducted at all the 29 cold chain points of Gwalior district during 1st October 2019 to 31st December 2019 and globally validated WHO UNICEF effective vaccine management tool was used for this study. Cold chain handlers at these cold chain points were interviewed and cold chain system was observed. Data was compiled in MS Excel and analyzed using percentage and proportions. Result of my study, there are 29 total cold chain points in Gwalior district and each cold chain point has one cold chain handler. It was found out that 38% cold chain handlers were males and 62% were females. Most of the cold chain handlers were in the age group of 51 to 60 years. Maximum number of cold chain handlers, that is 79.3%, were educated up to higher secondary. It was also found that the 58.6% of cold chain handlers were having a work experience of less than 10 years. This is the table showing that majority of cold chain handlers between the age group of 51 to 60 year of age, and majority of cold chain handlers were females, and work experience of majority of cold chain handlers was less than 10 years. And but it is yet but the training of cold chain handler in every 3 years 27 that is 93% receive regularly training. Only 62% cold chain handler demonstrate the correct way of reading the thermometer and only 18% has knowledge about shake test. Temperature logbook was filled twice a day by 44.8% cold chain handlers and 93% updated their vaccine stock register within 1 day of the transaction. It was found that 27.6% cold chain handlers had knowledge about early expiry first out principle, that is IFCO principle. It was found out that 93% cold chain handlers could correctly read and interpret BVM, that is vaccine while monitoring. Only 60.1% cold chain handlers know about cold sensitive vaccine, 42.6% know about light sensitive vaccine, and 89.6% know about heat sensitive vaccine. That is shown in this chart. Only 60% knows about cold sensitive, 42.6% knows about light sensitive vaccine, and 89.6% knows about heat sensitive vaccine. Discussion. More female participants in the study than males because majority of the health workers are nurses. All vaccines should be stored and handled under recommended conditions to ensure optimal protection from vaccine preventable diseases when they are administered. Provision of adequate equipment and implementation of a properly designed monitoring and control system are important components of a successful immunization program. Conclusion. The government health facilities had average performance related to the cold chain system, which is a matter of concern warranting for the cold chain monitoring. We recommended proper training and supportive supervision as the key measures in improvement of cold chain system.
Thank you, sir.
Thank you. Very nice presentation. I think we are running out of time.
If any of the speakers, any of the chairpersons have any questions for Anshul, Dr. Anshul, they're most welcome to address them.
Dr.
If
Shashank,
not,
if you could,
then we can move on.
Yeah, move on, please.
All right. Dr. Ashutosh, if you're ready, kindly present your screen, share your screen.
Yes, sir, I'm ready, sir.
Okay, sir. Dr. Ashutosh Saini,
Yes, sir.
Registration number 203. He will be speaking on the title Assessment of Improvement in Knowledge Amongst Trainees of Workshop on Vaccine Preventable Diseases. Over to you, sir. Kindly share your screen.
Hello.
Yes, sir, you're audible.
Your screen is visible. Visible, sir?
Absolutely, sir.
Oh, okay, sir. Good morning, esteemed chairpersons, and good morning, esteemed chairpersons and fellow doctors. My name is Ashutosh Saini. I'm from MBBS student batch 2019, NC Medical College and Hospital, Israna, Panipat. Today, I'll be speaking on the presentation of assessment of improvement in knowledge amongst trainees of workshop on vaccine preventable diseases. The introduction. The basic knowledge acquired during the learning phase fades away due to the passage of time if the knowledge is not refreshed or upgraded at regular intervals. The improvement in knowledge has been observed during refresher trainings amongst health service providers for delivery of quality services. The premier organizations have reorientation training programs regularly to adapt and improve the skills of health personnel for better results. The objective of my study was to assess the improvement in the knowledge of trainees in the workshop. The methodology. My study area was my college, NC Medical College, and the study design was to use a pre-designed evaluation test as regarding to the workshop. The study participants were 60 doctors from different specialties from the institute, and the data was collected via the questionnaire. In this context, it was felt to assess the improvement in knowledge of trainees and participants in one-day workshop on vaccine preventable diseases, organized under the aegis of WHO NPSP India in NC Medical College. And the results were, among 60 trainees, 63% had answered correctly all questions before the start of workshop, whereas 97% had the right answers after the end of workshop. 47% gave the right answer before workshop and 95% after, on the question of how many countries were still reporting wild polio cases, and on the question of how many diseases included in the VPD surveillance, that is vaccine preventable diseases, 80% answered correctly before and 98% after the workshop. And more than 80% had the right answer about the number of days to collect adequate stool samples for a suspect case of polio before the workshop, and 96% gave the correct answer after the workshop. The conclusion and recommendations are as follows. Although the level of general awareness among the participants and trainees was good enough, but some deficiencies were observed in specific about vaccine preventable diseases surveillance. From this workshop, it was emerged that if the reintegration workshops and trainings are organized at regular intervals, these would be quite beneficial for the health service providers to upgrade their knowledge and improve the skills for providing better quality services to the community. Thank you.
It has been a good try. Dr. Shashank, you can ask about the things, methodology and all.
Dr. Shashank, if you have any questions for this speaker, otherwise we can move on to the last two speakers of the session.
Can we extend beyond our time because it's already 12:35?
Yeah, that's fine, ma'am, but we still have to finish the speakers as well, ma'am.
Okay, okay.
All right. Thank you, Ashutosh, for your wonderful presentation. We will now move on to the final, to the last two speakers. Dr. Urusa, kindly share your screen. We have Dr. Urusa, who is
I'm here.
registration number. Yes, ma'am.
Hello.
Who is kindly share your screen and your
I did.
presentation. Dr. Urusa, we can't seem to see your screen at the moment. If it's not available, then we can open it from our screen as well.
Kindly tell her registration number.
Why do you share from your screen?
Her registration number is 310.
Yes,
Dr.
yes,
Urusa,
yes.
I will share your PowerPoint. Just a second.
Can you share my PowerPoint?
Yeah, just a second. All right. I hope it's visible.
It's visible.
Dr. Urusa, kindly begin the presentation and let me know when you want to change your slide.
Fine. Okay. My topic is knowledge of hands. Change the slide. Will you please change the slide? First of all, introduction. Hand hygiene has been recognized as a leading measure for reducing the incidence of healthcare-associated infections. Despite its simplicity, hand hygiene compliance rates are very low and remain uniformly low. Limited studies are available in context to hand hygiene awareness of nursing students, which are our future frontline workers in healthcare setting. So the present study was undertaken to assess the knowledge of hand hygiene practices among students of nursing college. Will you please change the slide? My aim and objective was to assess the knowledge of hand hygiene practices among nursing students. Change the slide. Study area was conducted in nursing college, Mother Mehban of SKIM Sora, and study design. This was just a cross-section study, and it was done in a period of 1 month. And I just chose the nursing students of 6th semester batch, consisting of 80 students. Change the slide. Will you please change the slide? Yeah, it was seen that maximum of students belong to the age group 20 to 23 years, that is 65%, followed by 18 to 20 years, 27.5%, and maximum were female students, 61.3%, and maximum, almost 95%, had received formal training in hand hygiene in 3 years. Change the slide. 51.3% of participants knew correctly the main route of cross transmission of germs between patients in healthcare setting. And majority, that is 61.3%, knew correctly about the minimal time needed for alcohol-based hand rub to kill the germs. And majority, that is 95% of respondents, knew that the hand hygiene must be done before touching the patient. Change the slide. 97.5% of study subjects knew that hand hygiene must be done after touching the patient, and 71.3% knew that the hand rubbing is more rapid way of cleaning hands than hand washing, and only 35 knew that hand washing causes dryness of skin more than hand rubbing, and hand rubbing is more effective against germs than hand washing. Change the slide. Conclusion: though 95% of our study subjects have received formal training in hand hygiene in the last 3 years, yet the knowledge about the same was not satisfactory. We conclude that nursing students had general awareness about hand hygiene, but they lacked specific information, especially about type of hand hygiene methods required in different situations. And hence, nursing students' knowledge about hand hygiene needs to be improved by regular theoretical and practical training sessions. Change the slide. Thank you.
All right, respected chairperson, if you have any questions for Dr. Urusa, kindly address them.
Dr. Anita, you can ask your the thing.
Hello, can I ask?
Absolutely, ma'am.
Yeah, thank you. Urusha, Dr. Urusha, as you have mentioned about nursing student, they already have in their curriculum and they study it from the very beginning of first year, second year, third year. And if still they are lacking, what is the, what do you think is the factors behind it? And I would like to ask you, what was the basis of calculating the sample size in your study?
Basically, it is a purpose of sampling method because we took all the students. It's not like we had chosen any specific group. 6 semester, all the 80 students were chosen, and theoretical knowledge is good and all, but like practicality is lacking. So hands-on training must be given to the students, like how to deal with the patients or what to do before touching a patient or after touching the belongings of patient. So hands-on is much better technique rather than
this is the group which have hands-on also along with theory. They are not just told theory, they are also told practicals also in their curriculum, in their student life, before the procedure, after the procedure. Then that means what is the implication or recommendation for future
Ma'am,
from
would it
your
be possible
study?
if you could make a question as concise as possible? We're running out of time,
recommend
actually.
they should properly go through the guidelines. Then before touching patient, they must wash hands. And it's not only like knowledge which they are having. It's a practical thing that they must know how it transmits the
Okay,
infection.
you can give solution to in your setting. Thank you.
Thank you so much, Dr. Urusa and respective chairpersons. I now request Dr. Afan Khan to share his screen. Dr. Afan Khan, there were some technical problems which have now hopefully been resolved. And his registration number, chairperson, is 271. He is our last speaker of the day. He will be speaking on tuberculosis treatment perception among tribal populations in Akola block of Ahmednagar in Maharashtra. Dr. Afan, are you there? Dr. Afan?
Hello?
Yes, Dr. Afan. Would you be presenting on your phone, or do you want me to present on my on the laptop?
Sir, it's better if you present on your laptop, sir.
Okay, let me
Because
just see
there's
if we
somewhat
have your
technical
presentation.
problems, sir.
All right, we have your presentation. Just give me a minute. I'll just open it. Can you stop sharing your screen?
Okay, sir.
All right. I hope it is visible to everybody on the screen. Dr. Afwan, over to you as a final speaker. Kindly begin. Your time starts now.
Okay, sir. Good afternoon, everyone. My name is Dr. Affan Khan, and my registration number is 271. Sir, next slide. My topic is tuberculosis treatment perceptions among tribal populations in Akolia block of Ahmednagar, Maharashtra, guided by Dr. Swanan Tirekar. Sir, how should I switch my slide? Introduction. Tuberculosis is an infectious bacterial disease caused by bacteria, Mycobacterium tuberculosis, that mainly affects the lungs. Worldwide, TB is one of the top 10 causes of death and the leading cause from a single infectious agent. In 2018, there were more than 10 million cases of active TB, which resulted in about 1.5 million deaths. More than 95% of deaths counted in developing countries and more than 50% in India, China, Indonesia, Pakistan, and Philippines. Tuberculosis remains a much major public health problem in India, accounting for a quarter of 8.6 million cases of TB that occur worldwide. TB control in high burden settings as tribal areas continues to face major challenges where efforts must continue to pursue, especially understanding treatment perceptions among these people in reaching the ambitious target to end the TB by 2025 under NSP 27-2025. Next slide. However, TB is curable. However, TB is curable and can be prevented. The treatment requires an elaborate drug regime, isolation, understanding of the disease course and its treatment modalities by both patient and its caregivers. The TB in India, revised National TB Control Program in India, nearly 2.5 million people develop tuberculosis every year, which accounts for 26% of the world's TB every caseload. Every year, nearly 4,000 people die due to TB. Aims to study the TB treatment perceptions among tribal population in Akolia block of Ahmednagar district, Maharashtra. Objectives: to study problems related to TB, to study knowledge, attitude, and stigma of TB. Next slide. Study design: qualitative exploratory study. Duration of study: August 2019 to April 2020. Study area is mostly from different villages of Akola Taluka in Ahmednagar district of Maharashtra, which is on the western Ghat of Maharashtra. And the population mostly consists of tribal people like Mahadev Kholi, Thakars, Bhils, and Ramoshis. And study population is Mahadev Koli, Thakars, Bhils, and Ramoshis. Material and method: inclusion criteria: people registered with DOT center and people with TB treatment for more than 3 months. Exclusion criteria: children below 18 years and people who have left the treatment. Sampling method: purposive sampling from patients registered with the health center. Data collection: in-depth interview. Next slide, sir. These are the ethical considerations, sir. Can you please move on to the next slide? Yeah. Results: most of the patients are aware how TB occurs, and they are well acquainted with the seriousness of the disease, and they know that cough, loss of appetite, weight loss, insomnia, fatigue, all these are related to TB, as well as they are having the knowledge that this disease spreads by hand greeting and close contacts. The admirable thing about the tribe is that they don't believe that this disease is hereditary, and they don't regard this disease as a social stigma. Most of the patients believe that the herbs are not effective in treating the condition, but because of poor access for medical services, they first approached the local handler and practitioner, because they believe in at government hospitals rather than approaching a private practitioner. patients with TB are not socially discriminated by tribal peoples, and there is no threat to their job if they are diagnosed with TB. Next slide. Most of the females require permission from their husband for medical access. On the basis of the score given, most of them believe that this disease has not affected their life severely. They are concerned about the illness, but it has not emotionally affected their life. They know this will have to take the treatment for long, but they totally believe that the symptoms they are having because of the disease will be completely cured by the treatment. As far as the TB score given by most of the patients responded well to the treatment and their score have improved after the treatment. Next slide. Discussion. TB
Dr.
is an
Afan,
infectious.
your time is up of 5 minutes, but kindly try and wrap up your presentation as soon as possible.
Okay, sir. So can you move on to next slide, sir? Next slide. Conclusion is patients who were poor and who remained sputum positive after completion of initiation phase of treatment were found more susceptible to unfavorable outcome. Programmatic approach should be specified to address the tribal and poor population by breaking the communication barrier. So next slide. Recommendations is mostly required for awareness program. There is a language barrier and healthy diet, health education, personal hygiene and safety precautions. These are the references, and thank you.
Thank you so much.
Thank you, Dr. Afan. It's a very good
Yes, sir.
presentation, and you can publish this if you want.
Yeah,
And,
sir.
is there Dr. Rita?
Yes, sir. I'll just comment on the one aspect like personal hygiene you have mentioned in this case, but it will be more
Yes, ma'am.
feasible if you add on the cough hygiene is more important in case of tuberculosis rather than personal, although personal hygiene is important, but cough hygiene has to be stressed upon more. So that you can add on. Thank you.
Oh, okay, ma'am. I'll add it, ma'am.
Afan has made a very good try. I think we have and we have missed out on Yangcheng Dolma.
Yes, ma'am.
Absolutely, ma'am. Yangchen Dolma has actually opted out of this in the last minute.
Okay.
But I think with that, we come to an end to this wonderful oral session. Thank you so much, Honorable Chairperson, for taking time out. It's been an absolute pleasure.
Thank you, sir.
Can I just share? Can I give you my vote of thanks to the organizers at AIMS Rishikesh for me and my chairpersons? Thank you, Dr. Rita. Thank you, Dr.
Thank you, ma'am.
Shashank. Shashank, I'll talk to you later
Okay,
because
ma'am.
I have touched with Varda too.
Yeah, definitely, ma'am.
And thank you very much for bringing us out virtually. It would have been very cold to reach Rishikesh. I'm from
Yes,
Dehradun,
ma'am.
so I love the place. I wish Dr. Shashank and Dr. Rita definitely visit Rishikesh. We are preparing for the
Yeah,
Kumbh Mela this time.
Yeah.
Thank you very
Ma'am,
much.
when did you visit Varda?
My husband, Dr. Devrat, did his PG from there.
Okay.
I stayed there for almost a year, way back in 98, 99.
Okay.
Okay.
So
I'll talk
nice
to you
to
later.
meet. Yes, ma'am. Definitely, ma'am.
Thank you. And thank you
so much.
especially to Dr. Anirudh. He has been updating us with the links. Thank you very much. Good effort done. And to all the presenters.
I also appreciate Dr. Anuruddh's work. He is working since morning, and from weeks together, he is doing such a wonderful job. Very good job. We should congratulate Dr. Anirudh for doing such a very good job. So
Thank you so much.
Thank you. Thank you
Same
very
here.
much.
everybody.
Same
Thanks
here
a lot.
for all of
Thank
you.
you.
And
Thank you, ma'am.
it is very I am grateful to the organizers all the organizers and my co-chairpersons to giving me this opportunity to be with all of you and share your experiences as well as mine and all the participants. Thank you so much.
Thank you so much, Sita ma'am.
Thanks a lot. Anirudh, you were a wonderful host. Thanks a lot.
Yeah.
Thank you so much. Thank you so much.
Thank you.
On behalf of Team
And
Eficon, we're very
we'll pass
grateful
on the
for
marks through Google Sheets. Okay.
Yeah, we have passed the marks.
Okay,
Thank you.
ma'am, we actually have one more session that's just slightly getting delayed. So thank you so much. I'll wrap
Yes.
this up if it's all right with you. Sincere apologies to the next session on in Hall B. We'll be starting very shortly. Thank you so much,
Yes,
everybody.
yes, definitely.
Thank you,
Request
sir.
to leave as soon as possible. Thank you.
Yeah.
We are waiting.
Hello? No, ma'am. I am in
A warm welcome to all the respected chairpersons for our oral session on the virtual mode on the topic EBPH, that is evidence-based public health. We welcome you on the behalf of Eficon 2020 on the National Conference of Epidemiological Foundation of India. I welcome our first chairperson, Dr. Debabrata Roy, who is professor and head of Department of Community Medicine at Cromon Dund Medical College, Dehradun. He is also chairman, State Technical Committee, COVID-19 Management at Uttarakhand. I welcome you, sir. Our second speaker is Dr. Gagandeep Singh, sir, who is Associate Professor, Mycology Section and Hospital Infection Control, Department of Microbiology, AIIMS, Delhi. I welcome you, sir. Third speaker for the session is Dr. Anmol Goyal, sir, who is Assistant Professor, Department of Community Medicine, Gyan Sagar Medical College and Hospital, Ramnagar, Punjab. Heartily welcome to all you, sir. We are going to start with our oral session with our four presenters. I request Dr. Sashank Gortakar, whose registration number is 353, who is going to talk on the topic malnutrition of under 5 children of Anganwadi in rural areas of Wardha district. Sir, please share your screen.
Yeah. Uh, you cannot start your screen while other
Sir, I have stopped
participant is.
sharing. I have stopped sharing my screen. You can start.
Yeah. So a warm good afternoon to all the chairpersons. Uh, Myself, Dr. Shashank Kotarkar. I am assistant professor in Department of Community Medicine, Jawaharlal Nehru Medical College, Wardha. My registration number is 353. Coming to the introduction part, nutrition is defined as the science of food and its relationship to host, and its concerned primarily with the part played uh, with by nutrients in the body growth, development, and maintenance. Any imbalance in nutrition leads to disorders in the body and ultimately to malnutrition or obesity. In India, each year 27 million children are born. Children between 1 to 5 years constitute 15% of the total population. It accounts to 25% of under 5 mortality occurring throughout the world. 10.6 million children die every year before reaching their 5th birthday. This is just according to NHFS 3 data in 2005-6. 46% of children below 3 years of age were underweight. 80% cases of undernutrition are mild and moderate cases. My aim is assessment of nutritional status of Anganwadi children, that is 1 to 5 years, by anthropometry and clinical examination in rural area, that is in Salod village of Wardha district. Objectives: to assess the nutrition status of children of 1 to 5 years age group in Anganwadi by anthropometry, to assess the nutritional status of children of 1 to 5 years in Anganwadi by clinical examination. Coming to the methodology part, the study was conducted in Anganwadi center of Salod village for a duration of 3 months by complete enumeration method. Participants were children of preschool registered in Anganwadi age group. The study was done from August 2019 to October 2019. August to October 2019. It was a cross-sectional study. The study tool was pre-tested, pre-designed, structured pro forma. The consent was given from the guardians of all the children present at the time of the study and Anganwadi workers. All the children of age group 1 to 5 years were included in the study. The data thus obtained was entered in the MS Excel, and data analysis was done in XPSS 23. Data was presented in the form of tables. May I request the chairperson, is my voice audible to you?
Yeah, you are audible very much.
Yes, you are audible.
Yeah, okay. So coming to the results, this is the table 1, distribution of children as per their age and gender. Boys almost less than 24 months of age, boys were only 1, girls were 3, and same wise, most of the children were 25 months to 36 months, that is 12 boys and 7 girls were there. So this is the according to the as per their age and gender. Coming to the next, that is distribution of children as per their mid upper arm circumference. Uh, Mid that is more than 13.5 centimeter, they have normal. Number are 40, and 12.5 to 13.5, that is moderate, mild to moderate, there are only 10 number of students. So this is as per the MUSC. Then distribution of children as per the ICDS growth charting. Most of the children, that is 82% children, have normal growth charting. Then ma'am, that is 18%, and Sam, there is no percent. According to distribution of children according to their skin examination, most of the it was found that normal skin were there among most of the male, that is 26 boys were having the normal skin, and 20 female have normal skin. Dry scaly skin 1, and 3 female have dry scaly skin. Then distribution of children according to their examination. Hair, normal hair, they have only 48%. Lousy hair, there are 6% male, and female were 40% and 6%. So distribution of children according to their eye examination. 50% boys have normal eyes, where 38% where have normal eyes. Pale conjunctiva, only 4% boys and 8% girls. Coming to the discussion part, I would like to have this table in present study, and I would like to compare it with the Kumar et al. Just a few more minutes. Age group 1 to 5 years, and gender was almost same. That is 54% were male, and in that study 46% were male. In our study 20% children were mild to moderate, and in Kumar et al. that is 12% below normal range. And our study shows very good
Sorry to
results.
interrupt, sir. Sorry to interrupt. Please wrap up in another 1 minute.
Yeah,
Please,
yeah,
sir.
yeah. Thus, summary and conclusion, the present study was conducted with the objective of assessing nutritional status of 1 to 5 age group children of Anganwadi in Salod village, Varda district. A total of 50 of 1 to 5 age group were involved for the period of 3 months, in which 54% of children were male and 46% were female. In the present study, all the signs of clinical and anthropometry point of view, like hair, eyes, face, nails, skin, etc., were taken into consideration. In the present study, 5 out of 50, that is 10% of 1 to 5 age group children were having grade 1 malnutrition, and this may be because of better coverage of Anganwadi centers in study area and good utilization of services by people from their Anganwadi centers. This is the recommendation. Children should be provided with more milk for better protein intake and healthier food which they like more. The Anganwadi workers should educate parents of children to provide locally available energy rich food, and use of safe water and proper sanitation should be taught by the Anganwadi workers to the parent. This is the limitation. The assessment of nutritional status involves clinical examination, anthropometry, biomedical evaluation, functional assessment, and assessment of dietary intake, vital health statistics. However, due to constraints like time, cost, and facility, the present study was limited to clinical examination and anthropometry. These are the references. Kumar et al. Nutrition Status Assessment, K Park and OP Guy. And thank you so much for listening the presentation.
Okay, may I comment? I'm Dr.
Yes,
Roy.
sir. Yes, sir.
Good afternoon, sir.
Very good afternoon. Dr. Shashank, the title, well, the way you suggested, perhaps
Yes, sir.
there are a whole lot of things amiss, in the sense that, of
Okay,
course,
sir.
at first, I'd like to tell you one thing. It's an humble suggestion that please do not burden your slides with so many words so that
Okay,
you
sir.
simply have to hurry through it. As
Yes,
such,
sir.
also ethically and technically, it is said that you shouldn't have more than 6 lines on a slide.
Yes, sir. 8x8 rule or 6x6 rule.
Yeah. You would have assimilated and learned everything, and you would be looking at the audience and simply say things. Only
Okay,
some
sir.
pointer reading should be there on the slide. And secondly, rural Varda. By rural Varda, I have been in rural Varda. You were talking to my wife sometime back. Okay, I am a
Yeah,
student
yeah.
of MGIMS. So
Okay,
I know
sir.
Salod village very well. You worked a lot.
Okay,
But
sir.
here, you have only one village, under 5 children of only one village. My question is, well, how much relevance your study has in terms of extrapolating these findings, whatever findings you have, into a larger scale? Okay, just keep it in your mind, because
Okay,
your
sir.
sample size is much low.
Yes,
Sampling
sir.
frame and sample size is much low, only
Yes,
one
sir.
village at one particular sort of area.
Okay,
Thirdly,
sir.
by anthropometry, you haven't told about any indicators of malnutrition or status, isn't it?
Okay,
Like,
sir.
we'll be talking about wasting, stunting, weight for age, वो 3 indicators बना के अगर आप करते तो
Okay, sir.
बहुत बढ़िया होता वो, है ना? आगे आप कर सकते हैं.
Yes, sir.
Otherwise, it
Definitely.
is simply description of a few findings, some proportions of students.
Okay, sir.
Anyway, thank you. Good
Thank
luck.
you, sir. Thank you, sir.
Oh, thank you so much, sir. Any other question from other chairpersons? You can go ahead, sir.
No, thank you. I'm Dr. Anmol. Thank you from my side. It's a good presentation. Thank you so much.
Dr. Gagandeep, sir.
Yeah, I don't have any question.
Okay, sir. Thank you
Thank
so
you so
much.
much, sir. Thank you. Thank you.
Thank you, sir. Now we'll proceed to our next presenting author, Dr. Jaya Prasad Tripathi, whose registration number is 332. We'll be talking on the topic, how effective was implementation of the package of essential non-communicable disease interventions. Over to you, sir.
Thanks a lot. Am I audible?
Yes, sir.
Yes, sir. Yes, sir.
Okay. The topic for today will be how effective was implementation of PEN, that is Package of Essential Non-Communicable Disease Interventions. This is basically a review of existing evidence, that is medical literature. Quickly brush through background because burden of NCDs in low middle income countries is not unknown to us. We have been witnessing a lot of mortality and it has been alarming. But to curb the rising epidemic of NCDs in low middle income settings, WHO developed a package of essential non-communicable disease interventions, especially for low resource settings, which is ideally a package of interventions including health education, promotion of healthy behaviors, early diagnosis of diseases like diabetes, hypertension, cancers, and the use of inexpensive, affordable technologies, and basically management at primary care facility. That's the main purpose of this package, and this package will be primarily delivered by non-physicians at a primary level, with an option of follow-up and referral and consultation with physicians when and whenever required. So this package has been implemented in a pilot phase in so many different settings, especially in low resource settings across several countries, including Bhutan, Korea, Myanmar, Indonesia, Philippines, and a lot of Central Asian countries. Evidence has been contradictory in some of these settings, but we need to assimilate this evidence and learn lessons from these pilot experiences in different countries. So this was the objective of this study, and we did a scoping review of outcomes and cost effectiveness of implementation of WHO PEN protocol implemented in different countries, and what are the challenges that they faced, so that we could be well informed when we design our own policies for our countries. So this review was conducted in accordance with the PRISMA guidelines, and a well-formed search strategy was designed. And we looked up the literature up to June 2020 in Medline PubMed databases, the Cochrane Trial Registry, and Google Scholar. Due to we were not able to search other big databases. Of course, that would have been wonderful, but due to resource limitations, we limited ourselves to PubMed, to Medline, Cochrane Trial Registry, and Google Scholar. The key inclusion criteria was studies which demonstrated the implementation of PEN protocol in low resource settings, and the important exclusion of studies were done based on other NCD interventions. If somebody has tried non-PEN NCD interventions in primary care setting, we have excluded those studies. And this was the flow of selection of studies. We could identify around 4,897 articles through various database searches, and after removing duplicates, we arrived at 4217. These were screened based on title and abstract, and 102 were assessed for eligibility, and so full text articles of 102 were reviewed. And out of 102, we were able to include 14 studies in this study finally, and many other studies were excluded from this 102 because some of them were review articles, letter to editors, and study protocols. Some of the studies did not assess PEN protocol, they were non-PEN NCD interventions. So out of these 14 studies, a content analysis of the results was done based on the key outcomes, cost effectiveness, challenges, and recommendations. These are the key outcomes that we looked at while we were doing content analysis. So this study included 3 economic evaluation studies, and they unequivocally agreed that implementing this PEN protocol is, of course, cost effective than a base case of no screening policies. Compared to no screening policy, it was cost effective. However, it could be improved through a targeted screening of high-risk groups. Rather than screening everyone, targeted screening will improve cost effectiveness a bit more. Many clinical outcomes were also studied, like reduction of risk factors after a year, reduction of risk factors after 3 visits, or changes in key behavioral and biological risk factors like CVD risk score, alcohol use, smoking, BMI. So a lot of key biological and behavioral risk factors were also studied. Most of these studied reported improvement in clinical outcomes like 10-year CVD risk, tobacco use, high blood pressure. However, the only concern here was the period of follow-up, which varied from 3 months to 2 years across very different studies. Some of the studies only looked at a 3-month outcome, which is a bit less. Although a 2-year follow-up study also demonstrated no difference between in pre-post intervention in some of the parameters, and they cited poor follow-up of patients, lack of medicines and equipments as the key reason for that. Patient perception was assessed in one study using participatory appraisal methods, and they found patients identified positive changes in NCD service delivery, more physical examination by a doctor. So better patient perceptions were noted. In terms of health system readiness, many studies expressed concern over availability of manpower, essential medicines and equipments. However, in centers where there were adequate availability of medicines and equipments, it led to better control of high blood pressure and blood sugar. The major concern in most of the studies were adherence to the PEN protocol in terms of poor follow-up, non-recording and miscalculation of CVD risk score, and poor documentation of CVD risk score, suboptimal recording of patient information. These were some of the challenges. We also listed out some of the challenges. I will not go through these in details. And there were a few recommendations. Because of lack of time, I will jump on to the final.
Yes, sir. Sorry to interrupt.
So the study, we reviewed the outcomes of implementation and its cost effectiveness, and it identified the factors which facilitated. I think the lack of medicines, manpower, and miscalculation, non-recording of CVD risk score, suboptimal recording of patient information, and loss to follow-up were identified as the key challenges. And countries who want to implement this PEN protocol must keep these challenges and barriers in mind before they roll out or expand PEN to other areas. Thanks a lot. Thank you.
It's a good presentation, Dr. Tripathi. Well, you have made it easier for us, through this meta-analysis. And it was a toilsome thing indeed, and very interesting and intelligent. You have gone through the effectiveness and outcome indicators, etc., very well in a concise way. Well, just one thing I was wondering, that should your title of the presentation be a question? It could as well be, because it sounds like a research question, how effective it is.
Yeah.
Could we perhaps make it an affirmative sentence? Because after all, you have done a review.
Right. Sir.
Like effectiveness of this, then dash a review.
Right.
Or a meta-analytical review. This is only a suggestion, nothing else.
Right. So my point of keeping it a question was because the evidence that came out was neither fully in support of PEN or fully denying PEN. So it's a bit of mixed evidence to PEN with some challenges.
Agreed. But usually we will find that when in an article or a paper, in question mode, in interrogation mode, the titles are usually not presented for that matter. But it's just as well. But you did a good job. Thank you. Nice presentation.
Yeah, nice presentation. Only thing I want to say is that, normally when WHO rolls out a program, especially for the low and middle income group, the prerequisites that are kept are usually to a minimum. And if we find that after PEN, we're back to square one, we are not being able to fulfill the prerequisites, and that is why the program is sort of failing in certain areas. So what do you have to say about that?
Right. So the purpose of rolling this out was to manage things at a primary care level, which sometimes is a bit overwhelming for non-physicians at the primary care level. So it might take until and unless we strengthen our primary care system, I feel this is a kind of burdening a bit more, especially the non-physicians who are already overburdened. So unless we strengthen them with infrastructure, with logistics, with knowledge, with the technical know-how, rolling it out is a big mistake.
Yeah, I think in addition
I
to
will just intervene. I just want to intervene with apology, Dr. Gaugandev. I have identified you there.
Yes, sir. How are you, sir?
Hello. No, actually, you have made a very relevant thing. I just couldn't restrain myself, and I wanted to observe one thing, that these international agency interventions, like one we had in Chakrata or disadvantaged block of Uttarakhand, they called it or named it as a minimum package of services intervention for disadvantaged areas. I tell you, they went along a few paces, then fell flat. The reasons are all too known. You were not ready, and highly ambitious things, rather academically achievable indicators only. And at the base, you were not prepared well, certainly not at primary care level. You do not have enough resource, no structure, no order, and no commitment also, no assimilation of your objective, all kinds of things. So high sounding international agency initiatives, how they have faltered and fumbled, and there are many among them we have seen.
Thanks.
Thank you.
Yeah. Thank you.
Thank you, sir. Thank you.
Thank you so much, sir. Any other question? Dr. Anmol, sir?
Yeah, not question. I just want to comment. Like, agree with Roy sir also, and even Dr. Tripathi. Like, I was a medical officer of various medical programs when I was in a civil hospital, Ambala Kent. Then I used to see that whatever programs are implemented by the authorities, international agencies or national agencies, they are not seeing the ground reality, like what infrastructure we are having, or what conditions we are having, or what man force we are having. So we are overburdened with the work. So like, if I take the example of measles rubella campaign, I was the nodal officer of measles rubella campaign, and there was a structure like you have one observation room, one waiting room, one medical officer room, one vaccinating room. But when we came to the ground reality, and when we went to a government school, they had only 2 rooms. Now, how can we make a one observation room, one vaccinator room, one day? So these are the things they have to keep in mind when they have to roll out the programs, seeing the ground reality, what actually we are facing. So it is right. We have to strengthen our primary health care. Thank you so much. It's a nice presentation. Thank you, Dr. Tripathi. Thank you so much.
Thanks a lot. Thank you.
Thank you so much, sir. Now moving forward, we have another presenting author, Dr. Shiv Kumar Yadav, to registration number 208, who will be speaking on a topic, a study to evaluate patterns of smartphone uses among medical students of Government Medical College. Over to you, sir. So please share your screen and unmute yourself.
My slides are on the desktop. How to share it?
Sir, there is an option of share your screen at the bottom of your screen, just green color. Yes, sir. Now,
Okay. Is it visible to all?
yes, sir. Now it is visible.
Yeah,
Please
it's
make
visible,
us like.
visible, very much.
Good afternoon, respected chairpersons. I'm Dr. Shiv Kumar Yadav. I'm here to present my study findings. It is a study to evaluate pattern of smartphone among medical students of Government Medical College of North India. Introduction. As you all know, the use of smartphone has increased tremendously, and basically the young people, they use it excessively. Medical college students are more vulnerable because of their heavy use of smartphones for study purpose and work purpose. Aims and objectives. The main objective of the study is to assess the pattern of smartphone usage among medical students and to assess their dependence on smartphone. Methodology. It was a descriptive cross-section study. Students were enrolled after obtaining the informed consent and IEC approval. Study setting, Government Medical College. 363 participants, MBBS students of first, third, and fifth semesters were enrolled. Study period was done for 3 months, from August to October 2019, with a semi-structural, self-administered validated questionnaire, as mentioned in the study below. Sampling method, purposive sampling. Inclusion criteria, students willing to participate in the study were enrolled. Exclusion criteria, those students who are not having any smartphone. Data analysis was done, data entry was done and analyzed with SPSS software. Means and ST are computed for continuous variables and percentage for categorical variables. Chi-square test was applied to look for any association. Not the results. This is a graph which shows the pattern of smartphone usage among medical students. As we can see, maximum usage. These questions were answered as a multiple response answer. So maximum usage of smartphone was done for WhatsApp messages, listening to music, talking with family and friends, and internet browsing and social media. As we can see on this graph. What is the context when the students use the smartphone at the maximum? When they're bored, when they're alone, on transport, while waiting for someone, in restroom. So these are the times when the students use the smartphone at the max. What does the student perceive basically? That why are they so much inclined towards using a smartphone? These are the questions that were asked to them through a 5-point Likert scale, from strongly agree to strongly disagree. And as you can see, majority of the students, they answered as strongly agree and agree that they perceive that they are strongly inclined towards the use of smartphone. They are not able to reduce the smartphone usage, and they feel themselves disconnected when they do not use the smartphone, and they use the smartphone for no particular reason. So this is the graph which shows that they are very much inclined. They also themselves perceives that they are very much inclined towards the use of smartphone. This is basically 20 questions that were asked to them on the Likert scale itself. These are standard questions which predicts their dependence, and based on the score that these students marked on these questions, they were categorized into various categories. 20 questions that were asked on Likert scale. Based on the response, 5 for strongly agree and 1 for strongly disagree. That these scores were obtained, and then their dependence was categorized into no dependence, mild dependence, moderate, and severe. As we can see, 8% were having mild dependence, 72% were having moderate dependence. That is very high, and 19% were having severe dependence. So we can see majority of the students have moderate to severe dependence over mobile phone usage. This is basically the demographic and the various variable categorization of the age and gender, semester, and daily cell phone usage. If you look at the semesters and the daily phone call made by them, it shows significant association with various levels of smartphone dependence. Daily phone call received, daily SMS received, daily WhatsApp message received, daily WhatsApp message sent. These also have shown a very significant association with the various levels of smartphone dependence. Conclusion: smartphone usage is very high among medical students. Moderate dependence is 72%, which has high probability of shift to the severe dependence. Semester students, phone calls made, text messages, WhatsApp messages have shown significant association with different level of smartphone dependence. Intervention should be planned at college level to encourage students to participate in cultural and sports activities and extracurricular activities for their overall development. Thank you.
Thank
you,
sir.
Dr. Shreev. Well, ethically, I being one of the authors, I just found that I was also author here. And Dr. Shreev is a very rather beloved resource in my department. So yet, impartially, I just want to highlight 1 or 2 points as an observation only. Here, dependence. Actually, the way we have measured dependence by Likert scaling, the parameters that we have used is inclination to use and use of, say, text, receiving calls, receiving text messages, etc., etc. But implication is much deeper here. We are perhaps talking about a dependency disorder, which pertains to almost, the way we would sort of envisage addiction and alcoholism and other associated phenomena related to it, like withdrawal symptoms and all. And it has got physical dependence, it has got psychological dependence, it has got a whole lot of ramifications and implications. So it is just as well that you have made a case, very good case for us to be alert here. Well, thank you very much.
Thank you,
Yeah.
sir.
Thank you, Dr. Shiv. I think that's a very important study which needs to be highlighted. And as Sir very correctly mentioned, that dependence is not just, what they think it is. I think even an evaluation from a psychologist or the scales that they use for dependence would also add to the study. And also,
Yes, sir.
one interesting finding what I saw was that out of 363 students that you interviewed, there were still 30 who do not use WhatsApp. So that's a surprising finding. I don't know of anybody using smartphone and not using WhatsApp. And just one question, because the basic theme of the conference is evidence-based public health. So what, according to you, will be the evidence that you've generated, and what's the way forward from this study?
So yes, sir. If you look at the curriculum of MBBS, basically the study focus on the medical graduates. So if you look at the curriculum of the medical graduates, from 9 to 5, they are involved in only the academic things. So we can basically recommend the NMC that there should be some kind of provision, at least 1 hour or half an hour that should be devoted for these children to go for some kind of sports or inclined towards other things also apart from their academics, and which will also improve their psychological, physical, and mental well-being. So this can be done. It has been added in the foundation course. If you see, they have separate hours, but that's only for 1 month. But we can push it for the whole curriculum also. This can be done.
Actually, Dr. Gagandev, I would like to say a few things.
Yes, sir.
Like this word evidence-based. Scientifically, of course, we need to have evidence to convince the scientific community that we have a research question here, and we will make a hypothesis, we will validate it. So, and we kind of build an evidence. There are other qualitative ways also to build evidence. But if we want to build an evidence, then we have to bring the context into the ambit of evidence seeking. जैसे ये एक प्रॉब्लम है या हो सकता है, ये कॉन्टेक्स्ट तो बने पहले, फिर जाकर के हम जो है ना, जैसे अभी शिव ने कहा कि हम लोगों को ऐसे ऐसे करना चाहिए, करिकुलम के अंतर्गत करना चाहिए, और ऐसे ऐसे कॉलेज अथॉरिटीज एंड द मैनेजमेंट शुड क्रिएट रूम टू, I mean, bring this kind of a context into the ambit of our thinking so that we can build research questions out of it. एक बार आपका research question बन गया तो evidence तो बनेगा.
Yes.
Evidence base is not something, it's in the sky or anything like that. Scientific community will not budge unless you hypothesize and simply apply statistical tools and convince them.
Very true. Thank you.
Thank you so much, sir. Moving forward with another presenting author, Dr. Nikunj Kumar Kansara, whose registration number is 165, will be talking on topic socioeconomic status and road traffic injuries among adolescents. Before moving further, I would like to remind you all chairpersons to kindly evaluate through that Google form provided. Thank you, sir.
Good afternoon, one and all. I hope I am audible.
Yes.
Yes, sir. Yes, sir.
Thank you. So today I am going to present the part of my short study. So today I will discuss the socio-economic status and road traffic injuries among the adolescents. So as we all are aware that every 4 minutes a child is prematurely lost on the roads of the world, and many more are injured. And Global Road Safety Report 2018 has also stated that deaths due to road traffic injury is almost 1.35 million a year. That means nearly 3,700 people are dying every day on the roads of the world. So the leading cause of death in the age group 10 to 19 years, and for children aged 15 to 17 years, it is the biggest threat to their lives. And more than half of the deaths are among the pedestrian, cyclist, and motorcyclist. And SDG 3.6 target is also there to halve the road traffic deaths and injuries. My aims and objectives of the study was to estimate the prevalence of road traffic injuries incurred among the school children during commute to school, and to assess if there any relationship between the socio-economical status and self-reported road traffic injury incurred among these children. And sample size was calculated to estimate the prevalence of road traffic injury among children with 5% error of margin. It came out to be at 248, but however, total sample of 364 children was taken. So my study design was the school-based, questionnaire-based cross-sectional survey, and study period was September to November 2019. And children from the age group of 14 to 18 years were included, and it was conducted in the 3 different schools of the urban part of Western Maharashtra. So why 3 schools? Because I included private, semi-private, and government. All 3 criteria I have chosen, so that as I am junior resident, final year PG resident, so I was not having time to go to the all schools. So I have decided to, I have selected 3 schools of the Pune, and stratified random sampling was done, and students with physical disability were excluded from the study. So this was my questionnaire, as you can see. And statistical analysis was done using SPSS version 20. So total 364 students were selected. Almost same boys and girls participated in the study with the mean age of 15.4 years with 1.1 standard deviation. So these were the reasons which prevent the children coming to the school by walk or by cycling. So as you can see, the traffic, heavy traffic is the biggest reason they have quoted for the to prevent the coming to the school by walk. And as you can see here in the bar diagram, that 44% has students have said that the roads are fairly safe, and 71% has quoted that the road safety is very important to them. So 51 students actually out of 364, 64 students have reported self-reported injury in the past 12 months, and 51 students required treatment from the doctor or nurse. So prevalence in my study was 17.6%, and absenteeism from this school was minimum 1 day to maximum 21 day, followed by the injury. And 26% students reported very high understanding. This was the self-reported only by the questionnaire. And 35% of students had average to limited understanding regarding road safety. So here we can see that higher proportion of the students reported road traffic injury, those who are having the limited knowledge, limited understanding about the road safety. And I did chi-square, and it was found significant. 62% of students belong to the socio-economical status class 2 as per the modified Kuppuswamy scale, and 19% were from the socio-economical class 2, 3, and 4 each. So here we can see that the class 4 students reported the highest proportion of injury, and it was found significant by chi-square test. Then I did multiple logistic regression by the SPSS, and I took reference category as class 2. So higher odds were found when we go down in the socio-economical status.
Sorry to interrupt, sir. So
Sorry,
please
ma'am,
wrap
bus
up in
last
another.
slide, ma'am.
Yes, sir. Yes, sir. Okay.
Yes. So here we can see that the children who walk suffered more road traffic injuries, and here we can see that by the increasing distance also the prevalence of road traffic injury increases. So in discussion, how safe is our roads? So with the previous study, it was found almost similar. So finally, to conclude, there is significant association found between mode of travel and socio-economical status, and awareness week regarding road safety should be observed in each and every school. Planning road safety initiatives should be planned appropriately, and there should be separate lane for cyclists and pedestrians, and there should be strict law enforcement and zero tolerance towards the common transgression. Thank you so much, sir, for patience listening, and over to you, sir.
Thank you, Dr. Nikunj.
Yes, sir.
Interesting study you have. In fact,
Yes.
to associate socio-economic status, for that matter, particularly with RTA. Well, statistics is a very interesting entity. It can tell you things which really do not happen. And well, it's a subject of probability. But I respect what you said, because your
Certainly.
sampling appears to be all right. Everything seems to be in order. But then a question remains is how effective would be extrapolating your finding in a larger scale? How many, because we have to consider study settings also, study settings and the population characteristics in a particular place.
Yes.
It's all done, you have a substratum, but we have to wait and see what other studies of similar veins say on this. Okay, now? And it is
Yes.
not merely socio-demographic attributes that you have associated. You have pinpointed socio-economic status by Kupusami and like that.
Sir,
And the
sir.
children, obviously then it homes down to people in a particular place or a pocket or a niche, with a particular socio-economic status in a study setting. But it is a representative sample you took. So I appreciate the way you went about it.
Thank you, sir.
I believe that it can be replicated and scaled up.
Yes.
Well, this much. Thank you.
Thank you so much, sir. Thank you so much.
Yeah, thank you so much. Interesting study, But what I feel is, what's the way forward? What are the things that can be changed, or how do you, what are the corrective measures that can be taken after this study?
Sir, corrective measures in, as I feel, sir, there should be, I have spoken already shown in the slides also, that there should be at least separate lane for the cyclists. You are aware, sir, that each crossing road is presently it is more difficult rather than having uh, any communicable disease, because as we are aware, sir, ki road traffic injuries are increasing just because of the not following rules. So these common transgressions, there should be strict law enforcement, sir, and
No,
zero tolerance policy should be there, sir, to.
sorry for interrupting. If you have to classify from doable, easily doable things to more difficult to do, so how would you
Yes, sir.
enlist?
Yes, sir. Sir, we are providing midday meal to the children in the rural areas by Anganwadi work, and this in the schools also, sir. So better, sir, that we should also provide the common like transportation facility also, those who are poor in the living in the urban slums, sir, or the school should be in the same locality. It should be there, or they should be provided those who are coming more than 5 kilometers. In my studies, sir, I have seen the children, those who are having 5 kilometer distance, also they are walking and coming in the urban areas. So in urban areas, sir, 5 kilometer walk is little bit dangerous. So those children should be earmarked, and free transportation should be given, sir, as per my point of view, sir.
So then, it's interesting the discourse. You see, it is after all the political willingness, isn't it? The strategists and the
Definitely, sir.
policy makers. And what you said is not something rocket science. A common man would also understand what is required. This is not the thing. Like Dr. Gagandeep said, what is easily doable. So easily doability ke andar, what we have to think about is what is achievable in our current resource constraintness.
Yes.
Available resource के अंदर क्या कर सकते हैं हम? First तो मुझे लगता है कि BCC जो behavior change communication is very important because the roads will not get overnight changed. Urban scape will not get overnight changed. But yes, public health legislation, it does have some role, of course. In changing intimate behaviors, it's not very effective. We know about that. But still, it has its own place. At the moment, I believe that public health legislation has got a role to play. And then awareness among the parents, caregivers, and of course the children also. The disciplining thing has to be there. And even the commuters, for that matter, have to be aware. And one, perhaps if they are not aware as such, you have to prod them to be aware. So the role of legislation. And otherwise, whatever you have said is very right. Well, if we can do that, if we can really convince the policymakers to make available such kind of entitlements and facilities, which usually do not happen in a country like us. I'm just like that, except, such kind of in academic discourses like this. So this is a very sorry plight indeed. Your finding is interesting indeed.
Thank you so much, sir. Thank you, sir.
Thank you.
Thank you so much, sir.
Thank you so much, sir. Any other question or comments?
Dr. Anjali, please go ahead. There is a shortage of time. Thank
Okay,
you so
sir.
much.
Yes, sir.
I'll
Yes,
just
sir.
take 1 minute. I just want to thank Dr. Gagandev, who has been a brother to me, and we haven't been meeting for a long time, but it's just as well that I met him here in this forum. And I thank him, the co-chair here, and I also thank Dr. Anmol Goel, who has been very kind and was very gracious and have been very, very sort of supportive. And their presence was rather very important and visible and very nice. I thank all of them, and I also thank the organizers for giving us this opportunity. Thank you.
Thank you so much.
Thank you so much, sir.
And I would like to thank the organizers for this opportunity. Thank you so much. And
Thank you so
it
much
was a
from
pleasure to
our
meet
end,
Dr. Roy, although online, but still.
Thank you so much, sir. This is from the session on the topic EBPH. All other presenters have opted out from the session. So this was the last presentation. Thank you so much for your time, sir. And
Okay,
take
Dr.
care.
Ankit, Anjali, I'll send my evaluation in a while. Okay?
Yes, sir. Yes, sir.
Okay.
Thank you.
Thank you.
Thank you so much, sir. Thank you.
Thank you.
Thank you.